Good morning to everyone and welcome to today's wonderful morning with Dr. Murli Bhardwaj. Nephrology and endocrinology are the two logically driven topics which we need to be very, very sure, right? So there are about 30 topics in nephrology and about 25 topics in endocrinology, which we are going to master now. Fanconi syndrome. Have you heard of Fanconi syndrome, Doc? Anytime anybody heard about Fanconi syndrome? Fanconi syndrome is a problem in proximal convoluted tubule. What is the importance of proximal convoluted tubule? Proximal convoluted tubule is also called the workhorse of the nephron. Glucose get reabsorbed, amino acids get reabsorbed, bicarbonate get reabsorbed, everything get reabsorbed significantly in the proximal convoluted tubule. That's the reason histologically proximal convoluted tubule is very, very, very rich in mitochondria because it's the workhorse. If there is any dysfunction in the resorptive capability of the proximal convoluted tubule, you lose bicarb, you lose glucose into urine, you lose amino acids into urine, you lose everything into urine because the workhorse is shut down. That is exactly called Fanconi syndrome. Fanconi syndrome is a dysfunction of which part of nephron? Very good. Then there is also we put it to power. Okay. So metabolic acidosis will occur. Why? Because bicarbonate is lost into urine. Phosphaturia leads to hypophosphatemia. And also there is hypokalemia. So quickly tell me, what are all the things that happen in Fanconi? Amino aciduria, glucosuria, bicarbonaturia, metabolic acidosis, hypophosphatemia, and hypokalemia. Then what are the etiological causes for the Fanconi and the proximal convoluted tubule dysfunction? Wilson's disease, copper deposition occur in all the places. Thyrosinemias, glycogen storage disorders, any ischemic necrosis of the tubule can lead to, and multiple myeloma and certain drugs like cisplatin, ifosfamide, antiretroviral drug, tenofovir, expired tetracyclines, outdated tetracyclines if consumed by the patient, because in India, every medical shop fellow is a doctor, right? So we think that MBBS, MD, DM, and then we are top. No, they are bigger tops than us. RMP, knows 78% of prescriptions in Hyderabad are written by non-qualified quacks. That is what the competition you are going to have, not from the other MD general medicine guys. Okay, so expired tetracyclines, lead poisoning, they all can lead to development of Fanconi. So the moment you are losing phosphate into urine, if there is no phosphate available, the bone growth get affected. That's the reason there is a growth retardation, rickets, osteopenia, etc., in case of Fanconi. So you should know everything about Fanconi. So how do you, is there any mnemonic to remember Fanconi? Etiology. The proximal convoluted tubule fails in the freakingly fallacious fanatical Fanconi. इतना गालियां देना आए तो अंग्रेजी में हम यहां नहीं बैठते. तो fructose intolerance, F. Then myeloma leading to nephrosis. Then chronic interstitial nephritis, tenofovir, forgotten tetracycline, and fragile forbidden paint chips, that means lead poisoning. They are all the causes leading to the Fanconi's anemia, is what Fanconi's syndrome is, what you need to basically remember. That is Fanconi. Barter's, Gitelman, Liddell's, they are the three syndromes you need to be thorough with. So there is something called nephron physiology, which you need to be very sharp. Understand, doctor? So all these sessions we will try to rush, but ultimately goal is what? We have a video library. Just by paying 999 rupees, we have only one plan called 999 plan. You get 300 hours of video content of all these contents, including PowerPoints, everything. That covers all 19 subjects, nearly around 54,000 high yield facts. So today only you are given medicine free, but actually surgery, gynocs, orthoped, everything is there. You can call us and then get a 999 subscription. 1 year आराम से पूरा ज्ञान वहां मिल जाएगा आपको. What is Barter? Barter syndrome is the problem in the thick ascending limb of loop of Henle. There is a glomerulus, there is a Bowman's capsule, there is a descending, then ascending limb of loop of Henle. In that there is one thick part, thin part. So you have a thick part before it becomes distal convoluted tubule. This is DCT, this is PCT, and this is the ascending limb of loop of Henle before it merges with DCT. You have what? Thick ascending limb of loop of Henle. In that, you have one co-transporter, sodium potassium 2 chloride co-transporter. What is the purpose of it? We don't want to lose sodium, we don't want to lose chloride, we don't want to lose potassium. They are important ions. So all the three will be reabsorbed into the surrounding interstitium by this sodium potassium 2 chloride co-transporter, which is located in thick ascending limb of loop of Henle. So here there is a reabsorption defect, which is called Barter. Can you tell me one common drug we give in pulmonary edema which also blocks furosemide, like loop diuretics are there, no? Torsemide, furosemide, bumetanide. So all these loop diuretics also go and inhibit thick ascending limb of loop of Henle, sodium potassium 2 chloride co-transporter. So it is like lifelong getting free Lasix from the birth because of the congenital defect in thick ascending limb of loop of Henle. So Barter will lead to all those side effects that occur with the loop diuretics. There will be metabolic alkalosis, there is a hypokalemia, hypercalciuria. What is a very famous dictum? Loop diuretics lose calcium into urine. Thyroid diuretics retain calcium into the body. Who loses calcium into urine? Loop diuretics. Same thing, hypercalciuria will occur in case of the Barter syndrome is what you need to remember. Okay? So there is also hypokalemia, hypercalciuria, metabolic alkalosis. They all occur in Bartter. Bartter is an autosomal recessive disorder, is what you need to remember. Now comes, there are two ways of preparing for exam. Metabolic alkalosis, hypokalemia, hypercalciuria is equal to Bartter. Boom. But in exam hall, is it hypo or hyper? Hypo or hyper? There's a dance, no, Prabhas? Huh? So hyper or hypo? Hyper or hypo? Unless you learn with reasoning. Let's look into that reasoning. Why you get hypercalciuria? Why you get metabolic alkalosis? Why you get hypokalemia in Bartter? So, बच्चों, sodium potassium 2 chloride co-transporter, loop diuretic and Bartter. In distal convoluted tubule, what do you have? Sodium chloride co-transporter. इधर पोटेशियम की मामला नहीं है. तो thiazide diuretics, either same thing they will do. It is called Gitelman syndrome. जो thiazide diuretics जैसे काम करते हैं by stopping, inhibiting sodium chloride co-transporter. Gitelman syndrome is also like that. Then you have a collecting duct where you have a epithelial sodium channels, ENAC. What will your aldosterone will do? It will come here, open the channel, reabsorb sodium and loses K plus H plus into urine. Epithelial sodium channels अगर open हो गया तो sodium क्या हो जाता? Body के अंदर reabsorb हो जाता. जब aldosterone कैसे काम करेगा? ऐसे काम करेगा. And you lose potassium and H plus ion into urine. But if there is Liddle syndrome, Liddle is a condition where epithelial sodium channels constitutively remain open. What is the meaning? Without aldosterone coming and asking them to open, without aldosterone only, genetically because of the mutation. What is that kind of mutation which will keep something activated? It's called gain of function mutation. What is that mutation which will inactivate something? It's called loss of function mutation. Bartter is loss of function or gain of function? Loss of function. What is lost? Sodium potassium 2 chloride channel. Then Gitelman is loss of function. Sodium chloride co-transported in distal convoluted tubule. Whereas Liddle is an example of gain of function mutation. Who is activated? Epithelial sodium channel. That is what you need to emphatically remember for the tomorrow's exam. Now, अभी बात करेंगे भैया ये काई को hypokalemia होता है. That is easy to understand. Bartter में. Because Bartter is inhibiting sodium potassium 2 chloride channel. So potassium is lost into urine. There is a kaliuresis. Hence there is a development of hypokalemia. Clear? Right? So why hypercalciuria in Bartter? This age जो समझ सकता ना उसके अंदर मसाला है. You should be a spicy guy in your knowledge base. Then you will be one-upman over everybody else in the world in competition. Right? And ultimately to treat patients, you don't need all this. You need to be a little better than RMP Sinu and medical shop, Lakshmi Medical Stores fellow. Understand? But to go to entrance, to kill the competition, to walk forward like a tsunami and then win in top 100 ranks, you require all this spicy knowledge. Okay? Now, Why hypercalciuria if you happen to give loop diuretic? Why hypercalciuria if there is a Bartter syndrome? इसके बारे में हम बात करेंगे. So what is Bartter doing? There is an inactivation of sodium potassium 2 chloride co-transporter. Understand? Because of that, what is happening? Sodium and chloride reabsorption is decreased. That means sodium and chloride are lost into urine. And because of that, there is a decreased intracellular potassium. Why? There is a reason for that. Whenever there is a impaired sodium reabsorption, sodium potassium 2 chloride channel, no? Potassium is depleted intracellularly. Because sodium and potassium are co-transported, no? So sodium depleted means sodium, potassium, 2 chloride are the 3 classmates going to coaching program. एक नहीं आए तो दूसरा भी नहीं आएगा. So sodium is decreased means साथ मिलके जाते ना coaching को. So sodium reabsorption is affected. Sodium is lost into urine. There is no sodium available to accompany the potassium for reabsorption. So because of that, potassium is depleted intracellularly. Did you understand? Mudunayandi, sodium, what are the 3? Sodium, potassium, 2 chloride. All the 3 in the thick ascending limb of loop of Henle decided that let us not go into urine. Let us get reabsorbed into interstitium and then into body. So the moment you inhibit it, what happened? Sodium is lost into urine. If there is no sodium available to accompany the potassium, right, that lead to potassium not ready to get reabsorbed because sodium is not available to accompany it. So the first potassium, what will it do? From the tubular fluid, it will go into the cell and from there it will get reabsorbed. So intracellular potassium levels will be diminished because potassium is not entering into the cell from the tubular fluid. Okay, that stimulates a channel called ROMK channel, ROMK channel. So this ROMK channel activity will increase. Then what will ROMK will do? ROMK will efflux the potassium out of the cell into the tubular fluid. And it will worsen the potassium reabsorption. It will make potassium lost into, more and more potassium lost into tubular fluid. So that will lead to potassium is lost into tubular fluid. That will lead to what is potassium positive ion? That will decrease the positive charge. That decreases the positive charge. Why? Because intracellular potassium is depleted. It is more and more effluxed and lost. And that will change the positive charge of the cell membrane. And that in turn will alter the electrochemical gradient required for the calcium reabsorption. And that makes calcium not reabsorbed. And calcium is also lost into urine. I'll summarize. Barters, or if you give loop diuretic, first thing what will happen? Sodium reabsorption is affected, sodium is lost into urine and there is a decreased amount of sodium. If sodium is not available, potassium does not enter into the cell. And that is the reason intracellular potassium levels are diminished. That will stimulate the ROMK. ROMK will cause efflux of potassium out of the cell. And that will decrease the positivity of the cell membrane. That in turn will affect the calcium reabsorption. And calcium is lost into urine. So sodium के वजह से पोटेशियम गया, पोटेशियम के वजह से कैल्शियम गया, कैल्शियम के वजह से सीट गया, क्योंकि नहीं मालूम है तो सीट मिस हो जाएगा. ओके, आई मीन फ्यू थिंग्स क्या है ना, कम से कम एक बार जिंदगी में सुनना है, क्योंकि tomorrow when you become gynecologist obstetrician, you will be busy in doing endometrial biopsy, PCOD, tuck, clomiphene citrate. Then you will be picking up the fertilized ovum and dropping. Where will you get time and need for Ramke? Right? But to become topper, you need all this funda. Now you know logically now. Fatafat bolo bede. What are all the things that you see in Bartter syndrome? There is a hypokalemia, hypercalciuria, problem in thick ascending limb of loop of Henle. It is like a loop diuretic use is what you need to basically remember. Finish. That is all the Bartter. Then comes Gitelman. Gitelman is like giving which diuretic? Which diuretic? Thiazide diuretic. Thiazide diuretic. Thiazide diuretic acts on which level? Distal convoluted tubule level. Thiazide diuretic inhibits which receptor? Which channel? Sodium chloride co-transporter. ఈ మూడు ముక్కును పెట్టుకోవాలి, ఈ మూడు పాయింట్లు ముక్కులో పెట్టుకోవాలి చీదడానికి ఎగ్జామ్లో. Now, Gitelman is a defect in NaCl co-transporter in distal convoluted tubule. In Gitelman, you get alkalosis, hypomagnesemia, hypokalemia, hypocalciuria. Opposite. There what you get? In Bartter, hypercalciuria. Gitelman mein hypocalciuria. But what is common between the two? Hypokalemia is common between the two. What is additional in this? Hypomagnesemia is additional in Gitelman. Gitelman is autosomal recessive. It is like a chronic thiazide diuretic use. Compared to Bartter, it is less severe. G for Gitelman is good. B for Bartter is bad. Okay? Sir, that's how you explain that electrochemical maintenance of electrochemical gradient. కొంచెం గట్టిగా చెప్పాలి. I suffer actually sensory neural deafness.
Sir, just now in the Bartter syndrome, you mentioned that this Na plus K plus co-transporter defect.
Right.
Okay? And you also explained that to maintain the electrochemical gradient, there is loss of potassium by activation of Romke channel and also calcium. But my doubt is both are positive charges, right, sir? Then how an electrochemical gradient is maintained by losing both the positive charges?
Correct. Actually, Romke channels activation becomes counterproductive. See, potassium नहीं है बोल के Romke channel activate करे तो Romke is causing further efflux of potassium, and loss of potassium is creating what? Loss of positive charge as an electrochemical gradient. Right? So, the positive charge in the membrane prevents the positively charged calcium to be lost into tubular fluid. But the moment this positive charge is gone, the calcium is driven more into the tubular fluid. If the positive charge is high, it will repel the calcium into the interstitium. If the positive charge is less, it will pull the calcium into the tubular fluid, and that leads to calciuria. 3 buzzwords. Sodium loss leads to potassium decrease intracellularly because there is no co-transport. that activates ROMK. That ROMK will further cause potassium loss. That will alter the membrane positivity, and that will suck the calcium out of the cells into the tubular fluid, and that is lead to hypercalciuria. Okay? Yeah. So now, first question. What are the things we need to now justify? Why there is a metabolic alkalosis, why there is a hypomagnesemia, why there is a hypokalemia, and why there is a hypocalciuria when there is Gitelman syndrome. You have two choices. You can remember this like a photographic print memory, one method. Second, logically understanding and remembering. Your choice, no problem. Right? First, metabolic alkalosis. Why does it happen? So what is Gitelman affecting sodium chloride co-transporter in distal convoluted tubule? मतलब नमक हलाल है हराम? हाँ, तो नमक हराम वो नमक को पेशाब में लूज कर रहे, right? NaCl is lost into urine. When NaCl is lost, NaCl carries with it कोचिंग सेंटर का कौन को लेके जाएगा? क्लासमेट को, वाटर को. So water is also lost into urine. When the water is lost into urine, what happens? There is a hypovolemia. There is a plasma volume contraction. Decreased plasma volume will decrease the renal plasma flow. Decreased renal plasma flow will cause the afferent arteriolar pressure to become glomerulus undandi. Afferent arteriole, here efferent arteriole. The moment there is a decreased renal plasma flow, the afferent arteriolar pressure diminishes. That will diminish the glomerular filtration and decreases the GFR. The moment GFR is decreased, the flow, the speed of the flow of the tubular fluid become diminished. If you don't have water in Musi river, it will slowly flow. Right? So, diminished. So, the moment that decreased slow rate of the tubular fluid is there, sluggishly flowing, then in the distal convoluted tubule, you are having juxtaglomerular cells. They will sense, ammo, the tubular fluid is going slow means there is hypovolemia, plasma volume contraction, decreased renal plasma flow, decreased GFR, बोल के sense करेगा. कौन? Juxtaglomerular cells in the distal convoluted tubule. Immediately they produce renin. Renin stimulates angiotensin. That lead to aldosterone production. And what will aldosterone will cause? The aldosterone, increased aldosterone will go to the collecting duct, and it will make the reabsorption of the sodium and loss of K plus H plus into urine. K plus H plus into urine. Loss of H plus into urine will lead to alkalosis. Alkalosis. Itna story hai. Quick repeat. Gitelman leads to NaCl co-transporter absorption get inhibited. That makes NaCl lost into urine. Along with that, water is lost into urine. That lead to hypovolemia. That lead to plasma volume contraction. That lead to decreased afferent arteriolar blood flow and pressure. That will decrease GFR. That will make the glomerular filtrate, the tubular fluid flow slow. That makes juxtaglomerular apparatus to sense and release renin. That stimulates angiotensin. That lead to aldosterone production. Aldosterone will come to collecting duct. It will lead to sodium retention, potassium loss, and H plus loss into urine. Loss of potassium into urine because of the hyperaldosteronism lead to hypokalemia. Loss of H plus into the urine lead to metabolic alkalosis. Two things finished. Why alkalosis is there? Why hypokalemia is there? Understood. Understood. Now, why there is a hypocalciuria? Why there is a hypocalciuria? NaCl loss into urine because sodium chloride co-transporter is there, no? Huh? In the distal convoluted tubule. That is inhibited, that is lost in, not functioning in Diddleman. So that low intracellular sodium in DCT will lead to, as a compensatory mechanism, will drive the calcium to get more reabsorbed with the sodium calcium exchanger. There is something called sodium calcium exchanger. What will sodium calcium exchanger normally will do? It will reabsorb sodium and lose the calcium into tubular fluid and into the urine. In the distal convoluted tubule, there is a sodium calcium exchanger. What it will do? It will lose the calcium into urine in exchange for sodium into the interstitium. The moment there is no sodium available to exchange for calcium, calcium is not lost into urine anymore. That leads to calcium reabsorption into the interstitium. That's the reason there is a hypocalciuria and calcium retention in case of Gentleman. You are a very special batch. Earlier batches I used to teach hypercalciuria is equal to what? Butter. Hypocalciuria is equal to Gentleman and walk away. मगर आप लोगों में शैतान बैठे हुए हैं यहाँ. खाई को होता है वैसा. So I have to prepare and come. Why it happens? बहुत दिन हुआ रॉम के बारे में long ago, somewhere in 2004. कितने साल है? 20 साल के पहले, probably in the same floor I taught Ramke. There used to be a brilliant guy called Raghuram from Usmania Medical College. And now he's a top gastroenterologist. He was sitting like you in the class. He was another guy who used to ask, why hypercalciuria? Why hypocalciuria? For him, I used to prepare. I was also very young, just to finish my MD General Medicine. I was ferociously academic. So, बहुत उसके बाद जो भी batches आए हैं, whatever you say, said, what to remember for exam, वो बताओ, right? So, try as much as possible to logically reason it. This image I gave, no. ChatGPT को पूछो, why hypocalciuria? Tap, it will give you. You don't need Murli Bharadwaj for that. Right? So, that is all the story, doctor. Now, next important thing. Why magnesiuria leading to hypomagnesemia in gentlemen? Fundamentally, in the distal convoluted tubule, there is a sodium chloride co-transporter. Right? So, the same way by which you require sodium for what will sodium will do? Sodium is required for exchanged with calcium, right? And you require certain amount of membrane positivity in order to reabsorb calcium. You also require certain membrane positivity to reabsorb magnesium also. The moment there is a hypokalemia, just like in where? uh, Bartter syndrome. Bartter syndrome, why did you have calciuria? Because there is no potassium, there is no positivity maintained. That's the reason calcium is lost into urine. By the same logic, magnesium is also lost into urine in case of gentlemen. But by the same logic, calcium won't be lost into urine. Because for the calcium to be lost into urine, what do you require? Sodium to get exchange. Here, primarily it is sodium chloride affected, where in distal convoluted tubule. That's the reason sodium depletion in case of gentlemen is significant compared to sodium depletion in Bartter. Okay, so that's the point you need to remember. Let's summarize. Let's not get too heavy on this. What is common between Bartter gentlemen? Pehla batao. Very good. What is unique with regard to calcium in case of Bartter and gentlemen? Hypercalciuria in Bartter, hypocalciuria in gentlemen. Utta clear hai? Then next, acid-base disturbances mein. Both of them will lead to metabolic alkalosis due to volume contraction, secondary hyperaldosteronism. That is clear. Then, what is unique with regard to divalent cation in gentlemen? Hypomagnesemia because of magnesiuria. Hypermagnesiuria leading to hypomagnesemia in case of gentlemen. बस शांति 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 ही समझ में आ गई ना which is severe which is bad gentleman is good Bartter is bad खत्म now comes little అసలు Bartter gentleman little renal tubular acidosis type 1 type 2 type 4 అర్థం చేసుకున్నారంటే చచ్చిపోతాడు ఎగ్జామినర్ I can bet it your examiner won't know the knowledge that you have. 200% I can bet it. Some Pullarao or Subbarao will come as examiner. Right? He is least interested to evaluate you in the Viva Voce. There's already match fixing done before his arrival. So why worry? But knowledge is for ourselves. That's the reason always definitely prepare for exam to score good, but you should get that happiness in studying medicine, line surgery, etc. Okay, so now comes Liddle. Liddle is a gain of function mutation in epithelial sodium channel in collecting duct. Because of that, what will happen? Even without the behest of aldosterone, the epithelial sodium channel remain opened and that will lead to enhanced sodium reabsorption. Right? But every time sodium is reabsorbed, what is lost into urine? Potassium and H+. Hence, there is a hypokalemia. Right? And also there is a metabolic alkalosis. And all this sodium reabsorbed will lead to vasoconstriction and hypertension. But what is the difference between Conn's syndrome and Liddle syndrome? What is Conn's syndrome? Whenever there is adrenal gland adenoma, that lead to hyperaldosteronism, which is called as Conn's syndrome. Right? So here, without aldosterone itself, epithelial sodium channel is open. Without aldosterone itself, epithelial sodium channel is open. That is the reason that retained sodium, what will it do to the aldosterone? Make a funda telsa? Low sodium stimulates renin-angiotensin to lead to hyperaldosteronism. High sodium will suppress the renin-angiotensin to lead to low aldosterone. That's the reason difference between Kahn syndrome and Little's is hyperaldosteronism is a feature of Kahn's, but hypoaldosteronism is the feature of Little. But what is common to both of them? Both lead to metabolic alkalosis, both lead to hypokalemia, both lead to hypertension, is what you need to understand. Then comes, what is the inheritance pattern? Earlier, gentlemen and Barton are what? Recessive. Whereas little is autosomal dominant. So how do you treat little? We give amiloride. Amiloride is the inhibitor of epithelial sodium channel. उनका mouth को close करेगा. epithelial sodium channel के मुंह को बंद करेगा. कौन? Amiloride. बस. This is all the ज्ञान that you require. Finish. Now comes potassium shifts. Where is potassium normally located? सेल के अंदर रहने वाला पोटेशियम, सेल के बाहर रहने वाला सोडियम, right? So actually we are missing a lot of our students, no? They are happy with the first three: cardiology, neurology, and rheumatology and hematology. Khatam, satiety aa gaya. So, because these are the things which require logical review. Amma.
Sir, in Liddle syndrome, there is loss of potassium and and sodium is reabsorbed.
Correct.
So, potassium is also a positive ion. It is getting lost. So, why there is alkalosis in the body?
Because we are losing H plus, no beta. Sodium is exchanged, reabsorption of sodium is against the loss of potassium and H plus into urine.
Because H plus is lost,
We get metabolic. Same reason. అక్కడ కూడా అంతే. మీ లిడిల్లోను తర్వాత బాటర్లో కూడా H plus loss into urine, K plus loss into urine. ఎందుకు? అక్కడ కూడా హైపర్ ఆల్డోస్టెరానిజం అవుతుంది. ఎందుకు? మీరు ఇప్పుడు బాటర్ తీసుకున్నారు అనుకోండి, జిటిల్మెన్ తీసుకున్నారు అనుకోండి, జిటిల్మెన్ ఇస్ అ ప్రాబ్లమ్ ఇన్ ద డిస్టల్ కన్వల్యూటర్ ట్యూబ్యూల్ and that is causing the sodium chloride co-transporter inhibited. That means sodium chloride is not reabsorbed. So sodium chloride is lost into urine. Because of that, along with that, water is lost into urine. That lead to hypovolemia. Hypovolemia stimulates secondary hyperaldosteronism. And aldosterone will come and cause sodium retention and loss of K plus H plus into urine. And that's the reason there is a metabolic alkalosis, there is a hypokalemia, even in Bartter, even in gentlemen, and also in case of little. Okay, now comes potassium shift. Very good. Unhesitatingly you ask questions. Then only this session is worth. Otherwise, आप भी पढ़ सकते ना. Notes दिया कैसा भी मैंने. Notes and Murli Bharadwaj, what is the difference? You can pinch. You can pin the teacher. Feel free. And another thing, don't feel about physiology రోజుల్లో చదవలేదు, నెఫ్రాన్, ఫార్మకాలజీ రోజుల్లో ఎమిలరైడ్ అంటే ఏదో తెలియదు, ఓహో ఇప్పుడు ఆ దిక్కులేని ఎమిలరైడ్ కూడా ఉన్నదా, అది కూడా ఎపిథీలియల్ సోడియం ఛానల్ని ఇన్హిబిట్ చేస్తుందా, ఈ విషయం నాకు ఎందుకు తెలియదు అని అన్నీ మర్చిపోండి. మీకు ఏం తెలియకపోయినా, ఈవెన్ ఇఫ్ యు ఆర్ ఏ బీటెక్ ఇంజనీరింగ్ స్టూడెంట్స్ ఆల్సో, ఐ నో హౌ టు మేక్ యూ ఎక్స్పర్ట్ ఇన్ బార్టర్ అండ్ జెంటిల్మెన్. క్లియర్? Will you promise me? Yes.
Sir, in Liddle syndrome there is hypoaldosteronism. Then why there is hypertension?
What is the question? కొంచెం సెన్సరీ న్యూరల్ డెఫినెస్ ఉంది.
Sir, in Liddle syndrome there is hypoaldosteronism. So why there is hypertension?
హైపర్ బికాస్ సోడియం రీఅబ్జార్బ్ అవుతుంది కదా, ఎపిథీలియల్ సోడియం ఛానల్ నోరు ఓపెన్ చేసుకుని కూర్చుంది కదా, కాన్స్టిట్యూటివ్లీ యాక్టివేటెడ్, దాంతో సోడియం రీఅబ్జార్బ్ అయింది కదా, ఆ రీఅబ్జార్బ్ అయిన సోడియం పోయి హైపర్ టెన్షన్ చేస్తుంది. కానీ ఆల్డోస్టెరాన్ ఎందుకు లో ఉంది? ఎప్పుడైనా కూడా ఆల్డోస్టెరాన్ లేకుండానే సోడియం రీఅబ్జార్బ్ అవుతుంటే ఆల్డోస్టెరాన్ పాపం డిసప్పాయింట్ అవుతుంది. ఆల్డోస్టెరాన్ లేకుండానే ఎపిథెలియల్ సోడియం ఛానల్స్ ఓపెన్ అయినాయి. మామూలు పర్పస్ ఆఫ్ ఆల్డోస్టెరాన్ ఏంటి? అది రావాలి, ఎపిథెలియల్ సోడియం ఛానల్ ఓపెన్ చేయాలి, సోడియం రీఅబ్జార్బ్ కావాలి. అది పర్పస్ ఆఫ్ aldosterone. The moment epithelial sodium channels are constitutively activated, sodium is reabsorbed. ఇంకా దాని అవసరం ఏమనేది ఆల్డోస్టెరాన్ది, అది సప్రెస్ అయిపోతుంది. మనం బాగా చదువుకున్నాం అనుకోండి, మెడికల్ కాలేజీలో ప్రొఫెసర్లు ఎందుకు పని లేక, జీతాలు ఎందుకు వాళ్ళకి కదా, అంతే. సో నౌ కమ్స్ పొటాషియం షిప్స్. Inside the cell is potassium, outside the cell is always sodium. So any shift of the potassium from the plasma into the cell leads to low potassium in plasma. Hypokalemia అంటే ఎక్కడ కెలీమియా? అది ప్లాస్మాలో, సెల్లో కాదు. I used to have వన్ స్టూడెంట్ కాల్ అరుణ. అమ్మాయికి ఎన్నిసార్లు చెప్పినా అర్థమయ్యేది కాదు. సార్ హైపోకెలీమియా, మరి పొటాషియం ఎక్కువ అవుతుంది కదా సెల్లోకి అని అంటే, సెల్లో కాదమ్మా, ప్లాస్మా బ్లడ్ ఉండే కదా, తీసి చూపించమంటావు బ్లడ్. షీ డిడ్ MD జనరల్ మెడిసిన్. షీఈ్ ఎ వెరీ గుడ్ ప్రాక్టీషనర్. ఎవ్రీ టైమ్ ఐ మీట్ ఐ టెల్ టు అరుణ, ఇగో పొటాషియం గురించి నన్ను అడగకండి. అట్లీస్ట్ హాఫ్ అన్ అవర్ విల్ బోత్ లాఫ్. సో పొటాషియం. సో potassium shifts into the cell, leading to decreased potassium in the plasma, which is hypokalemia. So what pushes the potassium into the cell? So hypoosmolarity. అంటే ఏంటి? మీ ప్లాస్మాలో వాటర్ ఎక్కువ ఉందనుకోండి, ఆస్మోలారిటీ ఆఫ్ ద ప్లాస్మా బికమ్ లో. ప్లాస్మాలో గ్లూకోజ్ బాగా ఎక్కువ ఉందనుకోండి, యూ గెట్ ఏ హైపర్ ఆస్మోలార్ ప్లాస్మా. If you give mannitol injection in a cerebral edema patient, mannitol is osmotically active substance and that lead to hyper osmolarity of plasma. Simple rule to remember: dehydration is a state of hyperosmolarity, overhydration is a state of hypoosmolarity. Hypoosmolarity will push the potassium into the cell, leading to hypokalemia. Clear? Second, H plus ion, K plus ion love to compete with each other to enter into cell. So what is alkalosis? The state of low H plus. So no competition. So potassium will run into the cell. So alkalosis lead to potassium to move more into cell and lead to hypokalemia. Whereas acidosis, what will happen? H plus ion will be more. It won't let the potassium to enter into cell due to competition. So potassium remains outside cell in the plasma. Hence acidosis is equal to hyperkalemia. Alkalosis is equal to hypokalemia. Is what you need to remember. नहीं है? इसको जरा पिंच करो. Afternoon, Associate Professor Mubin will teach you during lunch hours. आपको समझ में है? हाँ? She will tell. Come out, आप कोई उलझन में है? Daddy is finding a match for you. No? Let me first finalize whether the boy is suitable for you or not. More than your dad. Huh? Think potassium inside cell, in the plasma, it's moving out in. Speed thinking you need to have along with me. Then we will move forward. Otherwise, we'll be stuck with only half topics. By lunch hour, I am done with kidney. I have to go into endocrines. Okay? Now, come on. Acidosis mein kya hota hai? How many didn't understand? One more didn't understand, I will explain. H plus potassium are both in competition. If there is acidosis, high H plus is there in the plasma. So it will not let potassium enter into cell. Potassium remains in the plasma. That lead to hyperkalemia. Adoka method. Rondo method? Whenever alkalosis is there, it lead to hypokalemia. Okay. Then what is the most common cause of hypokalemia in intensive care unit? So we all give salbutamol, salmeterol, formoterol, all is beta 2 agonistic agent. एक बार ये फटाफट समझ लो बेटे. Alpha 1, alpha 2, beta 1, beta 2, 4 types of receptors. Quickly. Where is alpha 1 receptor located? It is there on the blood vessels. Any stimulation of alpha 1 receptors lead to vasoconstriction and BP बढ़ जाएगा. Prazosin like agents, 2.5 mg, 5 mg, 10 mg, they are all what? Alpha 1 blockers. Right? Then alpha 2, where is it located? It is located in our brain, central, alpha 2. The moment alpha 2 is stimulated, what it will do? It will block the sympathetic outflow from the brain. Blocking sympathetic outflow will lead to vasoconstriction or dilatation. Vasodilatation. That's the reason all the alpha 2 agonists like clonidine, reserpine, all these alpha 2 agonistic agents centrally acting will be sympatholytic, leading to vasodilatation and used as antihypertensives. Clear? Then you have beta 1 is located in only one heart, one girl, one love. Beta 1, heart. 2 lungs, beta 2 is in the bronchi, beta 2. So, beta 1 stimulation lead to increased heart rate. Beta 1 is also responsible for hypertension. So, beta blockers are what? Carvedilol, metoprolol, nebivolol. Forget all, dump them in bisoprolol. Only one all is all of all alls. That is metoprolol. 25 mg, 50 mg, bus. It will take care. So, it is beta 1 antagonistic agent. We are no more using propranolol, atenolol and all that. Gone are the days. Propranolol still used only for one purpose. Those who are having migraine में propranolol use करते. Essential tremor वालों में propranolol use करते. थोड़ा anxiety बढ़ गया, propranolol max. Otherwise, propranolol is not used in the modern practice. Clear? Then comes beta 2. Beta 2 is located in bronchi. Stimulation of the beta 2 lead to smooth muscle relaxation and bronchodilation. Beta 2 agonists are bronchodilators. But beta 2 also, that is salbutamol, salmeterol, formoterol, all these alls, they will make the potassium to run into the cell and leads to hypokalemia. That's the reason normal potassium is 3 to 5. 2.5 doctor, 2.3 doctor, 2.2 is potassium doctor. The cause is doctor. What doctor? It is the bronchodilators we are pumping into the patient is responsible in intensive care unit. Understand? There's a reason those who are COPD patients, who are bronchial asthma patients, you have to be watchful about their potassium levels. Clear? Another important thing. Doctor, yesterday 2.4, I have given part to chlor syrup, potassium. But don't give directly, it will burn the esophagus. Unless your fiancé is a gastroenterologist. Right? Potassium, pot chlor syrup need to be added to half glass of water and taken. You have to tell that patient 10 times. Right? Pot chlor cannot be consumed directly, which contain potassium. Clear? So, what is the point? Yesterday 2.6, doctor, we gave part load. Today also it is 2.4 only, doctor. What is the reason for a refractory hypokalemia? There will be concomitant hypomagnesemia. But what will you tell to Sister Lily? Don't be silly. Send his magnesium levels. Hypomagnesemia is there. Correct the magnesium, then only hypokalemia get correct. क्योंकि पोटेशियम मैग्नीशियम सोडियम के बीच में गठबंधन है. जब वो टूट जाता ना, सारे चीजों को फिक्स करना पड़ता. राइट? हाँ, गुड. सो डॉक्टर, asthma drugs typically lead to hypokalemia. Then insulin. Insulin you thought only will cause glucose to enter into cell. It will not only cause glucose, but also it will cause potassium also to move into the cell. That's the reason anybody receiving insulin is at a risk of developing hypokalemia. Right? Then what lead to shift out of the cell? Opposite of this. Synonyms, antonyms. Acidosis lead to hyperkalemia. Right? Lack of insulin deficiency. Insulin deficiency will lead to hyperkalemia. Potassium is intracellular ion. Anything that breaks the cell. Tumor lysis syndrome, rhabdomyolysis. YSR party fellows beaten, Telugu Desam party guy. His muscle is crushed into chintakai pachadi. So what happened? The broken muscle cells will release the potassium. Actually, Kondappa Reddy died not because of what? Of the injuries caused. He died out of rhabdomyolysis, leading to renal shutdown, leading to hyperkalemia, leading to cardiac arrest. Understand? Similarly, certain snakes, when they bite, viper and all, they lead to a lot of sloughing of the tissue. Right? Snake bite may. That also lead to rhabdomyolysis. Dying, if hair is there, hair dye. So what will happen? Husband के ऊपर angry होके वो housewife विमला ने क्या पिया? Hair dye. Hair dye is very powerful rhabdomyolytic agent, you know. Never in my life I could save the Vimala, Kamala, Amala who have taken hair dye. Because that lead to significant rhabdomyolysis, renal shutdown, dialysis karo, kuch bhi karo, hyperkalemia, itna rehta hai, suddenly they will go into ventricular cardiac arrest. Ventricular tachycardia and cardiac arrest. Understand? So tell me, doctor, crush injury, rhabdomyolysis, tumor lysis syndrome, they all lead to the development of hyperkalemia. Beta blockers. Beta 2 agonists are hypokalemia है तो बीटा ब्लॉकर क्या होना? Hyperkalemia. Similarly, NSAIDs, non-steroidal anti-inflammatory drug, what it will do? It will typically come to the juxtaglomerular apparatus and will cause the suppression of the renin production. Low sodium aldosterone, that lead to, if aldosterone is there, what will happen? Retention of sodium, loss of H plus K plus into urine, and loss of K plus lead to hypokalemia. High aldosterone is synonymous with hypokalemia. Low aldosteronism is synonymous with hyperkalemia. That's the reason NSAIDs are also known to lead to hyperkalemia. Got it, beta? हाँ. Second coating में हो जाता. जरा मुबिन को बाजू बिठा के सेकेंड व्हाइट वॉश डालो, आ जाता. पहले व्हाइट वॉश में थोड़ा कंफ्यूज हो जाओ. Confusion is also the beginning of wisdom. Do you know that? I'm becoming Sadguru. कंफ्यूजन होना है, कंफ्यूजन हुए तो ही हम हमारा लर्निंग स्टार्ट्स, है ना? हाँ, whether only when we are confused whether to say okay to रहीम या करीम, देन एटलीस्ट हम अली को शादी कर सकते। किसी को भी कबूल बोलने में अगर मोहब्बत करने में प्रॉब्लम है तो किसी को भी नहीं शादी कर सकते, है ना बेटा? सो दैट्स रीजन डोंट बी अफ्रेड दैट यू आर कंफ्यूज। कंफ्यूज मीन्स योर लर्निंग इज बिगिनिंग, इट्स लाइक वुंड हीलिंग। सो नाउ डॉक्टर, succinylcholine among the anesthetic agents will lead to hyperkalemia. So tomorrow when you go to the village, your grandma says, oh, my Shadan college granddaughter आ गया, देखो बेटे मेरा ECG देखो पहला देगा। इसके पहले क्या करते हैं? इधर उधर लगा के घुमा के हाँ अच्छा है बोलते हैं। अभी क्या करते हैं? What is the heart rate? What is the axis? Yesterday हमने बहुत शानदार पढ़ाई किया ना। Now you know how to interpret which axis, what, right? So your grandma asked, please take care of me. So you checked BP and gave beta blocker. थोड़ा घुटनों में दर्द है बोले तो NSAIDs दिया. And already she has diabetes and no insulin. No insulin lead to hyperkalemia, NSAID lead to hyperkalemia, beta blocker lead to hyperkalemia. By the time you got back into the train to Hyderabad, your wonderful Shadan treatment will lead to have to go to Alamia. So that's the reason drug interactions, doctor, always make a habit. Whenever you meet a patient, आप क्या ले रहे हैं यहाँ रखो टेबल के ऊपर, कैसे ले रहे हो बोलो। लिवोडोपा ले रहा हूं पार्किंसोनिज्म के लिए, हाँ वो हमको मालूम नहीं है वो डोसेज क्या है। आप कितना टैबलेट ले रहे हो बोलो। ये 110 mg वाले सुबह दोपहर और रात को भी लेने के लिए बोला। अच्छा, दैट मींस 110 mg TID will be given for Parkinsonism patient. Already he taught you without paying any fees. मैक्सिमम 30 ड्रग्स को अपने आप पढ़ाई करे तो भूल जाओगे। पेशेंट को कैसे ले रहे हो बोले तो वो रोज आपको 2-3 दवा नया दवा कैसे ले रहे बोलेगा। बस मिस्टर सिद्दीकी said the same metoprolol 50 mg, that means it is not 500 mg. 10 times सिद्दीकी भी ले रहे, सुब्बाराव ले रहे, पुलाराव ले रहे, कोई भी 500 mg नहीं ले रहे। 10 पेशेंट को देखे तो बीटा ब्लॉकर का डोसेज 12.5 से 50 तक है बोल के समझ में आएगा। उसके लिए कोई कोचिंग का जरूरत नहीं है। अंडरस्टैंड? I'll give you the list of 35 drugs I told you. I'm forgetting. I'll give you. बस वो 35 drugs. One of my patient also, while she was going to America, she said, Doctor garu koncham cheptara. I taught her 35 drugs list de diya. Loose motion laite rifagat eskondi, rifamycin. దగ్గొస్తే క్లామం వేసుకోండి, దాంతో విరోచనాలు అయితే గ్లీవో వేసుకోండి. బస్ దట్స్ ఆల్ ఈజ్ అబౌట్ రెస్పిరేటరీ ఇన్ఫెక్షన్. అలా కాదు కొంచెం యూరిన్లో మంట వస్తుంది ఆకలి వేయట్లేదు అని అంటే ఫెరపినామ్ డియోనెమ్ ER 300 వేసుకోండి, లేకుంటే నైట్రోఫ్యూరెంటైన్ వేసుకోండి. బస్ యూరిన్కి అంతే. తలనొప్పిగా ఉంది అంటే నాప్రాక్సిన్ వేసుకోండి. హెడ్ సెట్ అని ఒక టాబ్లెట్ ఉంటుంది, అందులో సుమాత్రిప్టాన్ ప్లస్ నాప్రాక్సిన్ కాంబినేషన్ ఉంటుంది. బస్ సో ఇట్లా లెక్క పెడితే MBBS అయినాక 30 మందులు తెలిస్తే చింత చెట్టు కింద కూర్చుని కూడా యూ కెన్ డూ ప్రాక్టీస్. इमली के पेड़ के नीचे भी बैठ के आशिया ना डॉक्टर आशिया सुपर हकीम बोल के फटाफट लिख सकते हैं आप। रजिया सुल्ताना का जैसे आप एक दिन संत आशिया बन जाओगे। उसके लिए एमबीबीएस का जरूरत भी नहीं है. एमबीबीएस is good. So all right. So that is the story, doctor, about hypo and hyperkalemia. Now dyslipidemias. Let us quickly run through them. How will hyponatremia present? Normal sodium कितना है बेटा? 135 to 150, 145. So ये 135 अगर 130 हो गया तो क्या हो जाएगा पेशेंट को? शुक्रवार को रविवार बोलेगा, रविवार को शुक्रवार बोलेगा. Altered sensorium. If this 130 become 125, वो इंडिया को अमेरिका से फर्क नहीं दिखता. 125 के नीचे हो गए तो फिट्स आएगा. 120 के नीचे 115 को गए तो कोमा में जाएगा. So इसलिए सोडियम प्रेजेंस विद नॉसिया, मेलाइन, स्टूपर, कुपर, सीजर्स. हाइपरनेट्रीमिया है तो इरिटेबल होगा, गाली देगा, बाद में स्टूपर एंड कोमा. हाइपोकेलेमिया है तो yesterday we have seen U waves, flattened T waves, muscle cramps, very common. Suddenly this muscle, that muscle will catch like a crocodile. So commonly people with muscle cramps, what will you tell? Eat banana. बनाना में पोटेशियम रहता, रोज 2 बनाना खाए तो नो मोर क्रैम्प्स. हाइपोकैल्सीमिया विल प्रेजेंट विद टेटनी, सीजर्स. ईसीजी में क्या होता है? हाइपोकैल्सीमिया में क्यूटी प्रोलॉन्गेशन, हाइपो में, हाइपर में क्यूटी शॉर्टनिंग. yesterday we have seen that ECG, no? Then there will also be Trocheau's sign, like a obstetrician hand. It will be like this. Then if you happen to twitch on the facial nerve, there will be spasm, chopsticks. Then hypercalcemia hai to stones, bones, bone pain, groans, abdominal pain, thrones, increased urinary frequency, psychic overtones, that is anxiety and altered mental status. Stones, bones, groans, thrones, psychic overtones is the feature of hypercalcemia. If hypomagnesemia hai to QT become prolonged. What is the normal QT corrected interval? Enta cheppale ninna chair class ki 420 milliseconds. When do you call prolonged QT more than 600 milliseconds? और नोट्स दिया ना, छोटा नोट्स, नॉट बड़ा वन, छोटा नोट्स, 160 pages. Every point, 900 points in cardiology, tuck, 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 like a parrot you should tell. Recite in sleep also. Then you are good in, I am telling you, topper in NEET PG is actually topper in general medicine, that's all. NEET PG को decide करने वाला gynecology, obstetrics नहीं होता, only general medicine. Okay. Now, hypermagnesemia, hyperphosphatemia, how do they present? You need to be very sure about. Now let us talk acid-base disorders. Acid-base disorders में you have metabolic acidosis, alkalosis, you have respiratory acidosis and respiratory alkalosis. One thing you should know, कार्बन डाइऑक्साइड को कहते हैं breathable acid. What is that? Breathable acid. If you exhale carbon dioxide, you are exhaling acid and you will end up in alkalosis. If you are hypoventilating, if you are not ventilating, respiratory arrest is there, then carbon dioxide is pent up in the body and that is equal to penting up of acid, and that's reason it leads to respiratory acidosis. Anxiety leading to hyperventilation, hysteria leading to hyperventilation. Hyperventilation is equal to respiratory alkalosis. Hypoventilation is equal to respiratory acidosis. Then metabolic is decided by who? Bicarbonate. More bicarbonate is metabolic alkalosis, less bicarbonate is metabolic acidosis. Simple. Neither respiratory acidosis, alkalosis or metabolic acidosis, alkalosis को decide करने वाला H plus नहीं होता. H plus is common denominator. But it is the bicarbonate, carbon dioxide which are the defining factors in acid-base disturbances. Clear? Now let us start the game. Metabolic acidosis may pH will be decreased. Right? Then PCO2 will be not decreased, increased. No, compensatory nahi. PCO2 per se is okay. All right. I got that. This is compensatory mechanism, PCO2. Why? Once metabolic acidosis lead to low pH, that will make the person acidotic hyperventilation. That will purge out the carbon dioxide. Hence, PCO2 levels will be diminished. Good. Then bicarbonate is fundamentally decreased in metabolic acidosis. And what is the compensatory response immediately? Hyperventilation leading to fall of PCO2. Clear. Then metabolic alkalosis. pH is increased, bicarb is increased. Compensatory mechanism is hypoventilation, which lead to PCO2 to increase. Clear? Then comes respiratory acidosis. pH is decreased. Primary mechanism is hypoventilation leading to PCO2 get increased. Hypoventilation is responsible for respiratory acidosis. That increased PCO2 will leading to respiratory acidosis immediately will make kidney to compensate. How does it compensate? By retaining bicarb. That's the reason bicarbonate is increased as a compensatory response. But for a metabolic acidosis to have respiratory compensation is easy. If you have a metabolic acidosis, you will quickly overbreathe and purge out the carbon dioxide. But for kidney to wake up and study nephrology textbook and then plan to retain bicarbonate, it will take time. That's the reason always the renal response compensatory mechanism to acid-base disturbances is a delayed response. Then comes respiratory alkalosis. Alkalosis, so pH is high. Primary mechanism is respiratory due to hyperventilation. That's the reason PCO2 is decreased, compensated with loss of bicarb into urine leading to bicarb levels to fall down. But this much is all that you need to know. So what is Henderson-Hasselbalch equation? pH is equal to 6.1 logarithm of bicarb concentration. I think somewhere slash is missing. Just check that. What is the Henderson-Hasselbalch? Now comes Winter's formula. What is Winter's formula? Metabolic acidosis hai to there is a respiratory compensation. Right? Whether it got compensated or not, you will know by Winter's formula. Right? So, suppose metabolic acidosis hai to, what is the respiratory compensation? Hyperventilation leading to fall of PCO2. So whenever metabolic acidosis is there, अगर pH इतना गिर गए तो PCO2 क्या होना? If pH falls with metabolic acidosis primarily, compensation is what? Hyperventilation leading to fall of PCO2 also. अगर pH इतना गिर गए तो PCO2 कितना गिरना as a compensation, इसको कहते हैं Winter's formula. Similarly, metabolic alkalosis hai to what will happen to pH? Increased. pH is more than 7. Then what is the compensation? Hypoventilation and the rise of PCO2. तो मेटाबॉलिक एल्कलोसिस में pH इतना उड़ गए तो बढ़ गए तो कितना PCO2 बढ़ना, इसको कहने वाला चीज को क्या बोलते हैं? विंटर्स फॉर्मूला. So what Winter's formula says is PC, not pH, sorry, bicarb. I told the relation is between H plus and PCO2, no? It is not between H plus and PCO2. It is between bicarb and PCO2. Understand? So, first of all, tell me, metabolic acidosis में bicarb क्या होता? Acidosis में bicarb decreases. That will lead to hyperventilation and PCO2 also will fall. So bicarb इतना गिर गए तो PCO2 कितना गिरना. मेटाबॉलिक एल्कलोसिस में bicarb इतना बढ़ गए तो PCO2 कितना बढ़ना. इसको विंटर फॉर्मूला बोलते हैं. तो इसका फॉर्मूला क्या है? PCO2 which is expected is equal to 1.5 into patient's bicarbonate level plus 8 plus or minus 2. Plus or minus 2. That means this is what PCO2, predicted PCO2. And you will also measure the PCO2. Then compare predicted PCO2 with measured PCO2. If they both are equal, means it is fully compensated. Okay? Let's see one example case. Patient's pH value is 7.13 and his bicarbonate value is kitna? 20 and his measured PCO2 value kitna? 38. अगर bicarb value 20 है तो, right? What is when the bicarb value normally is 20 to 29. 20 means what? Low bicarb. Low bicarb means what? Metabolic acidosis. Metabolic acidosis. अगर metabolic acidosis है तो what is the expectation on the PCO2 as a compensation? You expect to see low bicarb hai. Low bicarb means metabolic acidosis. Metabolic acidosis hai to person will hyperventilate and exhale the CO2 out. So his CO2 is expected to also fall. Understand? Now let us see what is the predicted CO2 levels. 1.5 into patient's bicarb value plus 8. What is the patient's bicarb value? 20. 20 into 1.5 is equal to 30 plus 8 is equal to 38 plus or minus 2 is what? 40 or 36. And actual value of the bicarb kitna nikla? 38. That means what will you tell here? Patient had metabolic acidosis because of the low bicarb. At the same time, his PCO2 also has fallen down to 38, the actual value, and the predicted value according to winter formula is also 38, and hence he is fully compensated. So entrance may, this is what seat winning question. बाकी चीजें सब लोग आंसर करते. मिड ओव्युलेटरी साइकिल में एलएच बढ़ेगा या एफएसएच बढ़ेगा, वो तो आम आदमी क्वेश्चंस हैं. स्पेशल क्वेश्चंस होता है ना, स्पेशल चाय इन नीलोफर कैफे मींस एक्स्ट्रा 20 रुपीज मोर, राइट? सो स्पेशल चाय वाला क्वेश्चंस को जो आंसर करेगा ना वो आगे बढ़ेगा. सो सर मैं पूरा साल प्लान ए पढ़ा, प्लान बी पढ़ा, प्लान सी पढ़ा, बाद में ये कोचिंग अटेंड किया, वो कोचिंग अटेंड किया, फिर भी मेरा स्कोर नहीं बढ़ रहा है. काइकू बोले तो आप हर एक बार जब पढ़ रहे हैं ना एसिड बेस चैप्टर को अवॉइड कर रहे हैं. Our natural tendency is what, when we start revision of gynecology means, or when we start a revision of anesthesia means, MBBS days mein we studied succinylcholine super duper. So we'll only read succinylcholine. Every time we open anesthesia, we only read succinylcholine. We forget about propofol, 2-3 points about it. The maple sun circuits, about dangerous topic in anesthesia. Have you heard? At least that there is a topic like that. Maple sun, A system, B system, C system, Magill circuit. वो सब पढ़ने के लिए हिम्मत होना है. SPM बोले तो insecticide classification. Insect classification. Which insect will sleep like this and release the eggs? Which insect will be feeding the bottom? Which insect will be swimming on the top? Which will be doing butterfly? Which will be doing backstroke? ये सब पढ़े तो ही सीट मिलता, नहीं तो नहीं मिलता. कार्डियोलॉजी का ख्वाब ही रह जाता. Understand? So that's the reason, doctor. Critical topics like acid-base Bartter syndrome, Little syndrome, all these things you should be good. Now comes the next favorite topic, renal tubular acidosis. इसमें language ही खराब है. The very topic starts with confusion. कई को distal renal tubular acidosis को type 1 बोलते, proximal renal tubular acidosis को type 2 बोलते. Too much, no? So you are having what? Glomerulus, Bowman's capsule, proximal convoluted tubule, distal convoluted tubule, and collecting duct, right? Any proximal convoluted tubular problem ko kya bolte? Type 2. Distal part, that is collecting duct part में problem है तो इसको क्या बोलते? Type 1. 2 पहले आता, 1 बाद में आता. Then luckily there is no type 3. Type 3 they thought of proposing, meanwhile all India PG became NEET PG. Right? Type 4 is there. Okay? Now about each of it, 5-6 points master and move forward. Okay? Acha. Why, when there is a renal tubular dysfunction, there is an acidosis? Because the kidney's primary job is what? To get rid of acid from the body safely out into the urine. That's the function. Any problem in kidney will cause a problem in excreting the H plus ion, leads to the development of acidosis. So, in this process of cleaning the acid from the body, how will proximal convoluted tubule contribute? It will typically cause the reabsorption of the bicarbonate into the body, which will go and buffer the acid. If the proximal convoluted tubule is not working, bicarbonate reabsorption doesn't occur, bicarbonate lost into urine, hence there is no bicarbonate available to buffer the acid in the plasma, and that lead to acidosis. Second, what is the function of the distal convoluted tubule? It will secrete H plus into urine, secrete H plus into urine. If the distal convoluted tubule is not working, nobody to secrete H plus into urine, and H plus remains in the plasma, and that lead to development of acidosis. Now let us start about distal renal tubular acidosis, which is called type 1. First of all, why there is a metabolic acidosis in distal renal tubular acidosis? There are cells called alpha intercalated cells in the collecting duct. क्या नाम है? Alpha intercalated cells in the collecting duct. Their function is to secrete the bicarb. Secrete the bicarb. And they lose their ability to secrete the, sorry, not bicarb, H plus. They lose their ability to secrete the H plus. That lead to metabolic acidosis is what you need to remember. So now let us look into what is exactly happening in this scenario. In distal convoluted tubule, there is an impaired H plus secretion because alpha intercalated cells काम नहीं कर रहे. Because of that, what will happen if there is no H plus secreted into the urine? The urine cannot be acidified and the urine pH inappropriately will remain alkaline. Every time you look at urinary pH, what will be the pH value of the urine? More than 5.5. Okay? And all that accumulated H plus in the blood, which is unable to get secreted into urine, typically will lead to metabolic acidosis. Normally in that scenario, what will proximal convoluted tubule will do? अयो मेरे बहन कलेक्टिंग डक्ट ने अल्फा इंटरकेलेटेड सेल खो गया, इसके वजह से पूरा H प्लस आयन्स ब्लड में एक्यूमुलेट हो रहा है बोल के ये क्या करेगा? proximal convoluted tubule normally reabsorbs more bicarb and try to compensate it. But if the amount of acid collection is beyond the compensatory bicarb reabsorption in the proximal convoluted tubule, that leads to development of acidosis. Okay? So God created human beings in such a way that there is no need for doctors. Always remember, right? So yesterday we admitted one patient now in the morning. He has got a lymph node swelling. It is thought to be TB possibly, right? So we admitted him. Then we planned for excisional biopsy, but WBC count came 17,000. Early morning, 2:30, I got a call from the intensivist. Patient had a cardiac arrest. Wow. 63, very young age. 63. Right? So I had to rush, but our intensivist by the time resorted that bradycardia को revert कर दिया, ventilator पे लगाया, right? Venous line, arterial line, dialysis, all शराब मामले. So I went and consoled the patient's daughter. That is a ultimate job of you being clinician is not treating. Senior physician means console until your shoulder is wet with the tears of the patient. So I came at morning 4:30 back to just to doze into sleep. So the patient reverted. Evening we are extubating him. Because it's only transient, parapharyngeal area mein abscess will cause compression of vagus. That lead to cardiac arrest. Not due to MI or inferior wall MI, luckily. So morning only I spoke. What I'm telling you is, principles will be very less. But you should understand the principles. You should observe in about 100 people. You need to do mistakes in your judgment in 20-30 cases. Then only you will emerge as the great star physician. Nobody will be nationally star. If somebody said that, he is a fool. Right? Now, doctor, serum potassium level in distal renal tubular acidosis diminishes. इसका story क्या है? क्यों होता वैसा? So typically in a distal RTA, H plus secretion is impaired. And what did we study earlier? Reabsorption of the sodium is linked with in collecting duct mein excretion of H plus and potassium into urine. If the H plus is not secreted, sodium is not Sodium, what should happen to sodium?
Hypernatremia. Hypernatremia.
Sodium retention is related to H plus secretion. No, if H plus secretion is impaired, sodium reabsorption should also impair. No, somewhere it went wrong. Right? Huh. Sodium reabsorption should get affected if H plus secretion is affected. So for now, I'll keep this in the side bin. Okay. So there is a hypokalemia in distal artery because H plus is co-secreted with what? Potassium. Then that should lead to hyperkalemia, right? Somewhere there is a gadbad in this, we'll come back. But remember, there is a hypokalemia. There is a hypokalemia. Okay? I'll tell now. I understood. No, it's still against my logic. But anyway, hypokalemia is there. I'll come back. At this point didn't come to my mind. Afternoon lunch break, why there is a hypokalemia in distal artery is a homework. Huh? You know, when teacher says homework, that means he did not understand the concept. Huh? Now, why there is an increased calcium phosphate kidney stones in distal artery? इसके बारे में चर्चा करेंगे. Fundamentally, in distal artery, what is there? There is metabolic acidosis. That means there is high levels of acid in the blood. And what will kidney will attempt to balance this acid base status. Right? Now, the moment in distal artery, H plus is not secreted into the distal tubule, tubular fluid will be alkaline or acidic? Alkaline. So tubular fluid is what? Alkaline. And this alkaline environment of the tubular fluid will favor the calcium phosphate to get precipitated and form a stone. Reason number one. Till now, no objection. Another thing. Distal renal tubular acidosis is a state of acidosis. When there is an acidosis, it will go to the bone. Right? And bone provide the required buffer to neutralize the acid in the body. There is a principle of different buffers available. Phosphate buffer, bicarb buffer, etc. Buffer systems in the body. So when there is an acidosis, typically the body attempts to buffer the acidosis by releasing the calcium and phosphate into the plasma. So this high calcium, high phosphate will ultimately get filtered and enter into tubular fluid. And already tubular fluid is alkaline. So it is very attractive environment for the calcium and phosphate to marry each other. Understand? And who released calcium and phosphate? The bone. Why did bone release them? To buffer the acid. Why there is an acidosis? Because of the impaired H plus secretion by the collecting duct. Clear? Now, there is another important point we need to know about distal renal tubular acidosis. Where is citrate reabsorbed? Citrate, bicarbonate, everything is reabsorbed in the proximal curvature tubule. So in the distal renal tubular acidosis, how is the proximal curvature tubule? It is normal. That's the reason whenever there is an acidosis, the proximal curvature tubule will wake up and try to reabsorb more and more citrate. Because of that, tubular fluid में citrate कैसा है? Low levels है. So there is a reduced urinary citrate levels. And reduced urinary citrate has an effect. Why? Calcium जो tubular fluid में है, इसको दो चांसेस है, वो फॉस्फेट को भी शादी कर सकते हैं, सिट्रेट को भी शादी कर सकते हैं। अगर सिट्रेट नहीं मिले तो फॉस्फेट को शादी करेगा। सो ए हाइपोसिट्रेटूरिया, low citrate levels in the tubular fluid, because citrate has gone to buffer, वो काम पे दुबे गए, और ये इसके लिए वेट किया, नहीं अवेलेबल है तो mama son is also okay. So it married mama's son who is phosphate. That's what you need to basically remember. That's the reason calcium phosphate stone formation is because of hypercalciuria, hyperphosphaturia with alkaline urine, and a urine with a low citrate levels contributes to the calcium phosphate stones only in distal artery, not proximal artery. Favorite question of the examiner. Clear? So let us summarize. Distal RTA is inability to alpha intercalated cells to secrete H+, leading to metabolic acidosis. The urine pH can never be acidified, because to acidify urine, what do you require? H+ secreted into urine. Either H+ is not secreted into urine. That's the reason urine pH always remains alkaline. Serum potassium levels are low. I will check that and tell why it is low. Then what leads to distal renal tubule to get screwed up? Amphotericin B toxicity, favorite MCQ in entrance. Analgesic nephropathy, diclofenac. If you go to government hospital, Mehboob Nagar, ever unde Mira, a government Ramkishan will keep writing. Overon. Only Overon will be there. If you go to government hospital, Overon leading to analgesic nephropathy, bundles and bundles of cases. Even patients volunteer that. డాక్టర్ గారు ఈడ సట్టల్లో నొప్పిగా ఉంది, ఈడ కాళ్ళల్లో నొప్పిగా ఉంది, నాకు నొప్పి భరించలేకపోతున్నాను, జర ఓవర్ అని గొలి రాసి రాదు. ఈజ్ వాట్ ఈవెన్ ఏ నర్సమ్మ ఆల్సో విల్ టెల్, పిచ్చమ్మ ఆల్సో విల్ టెల్. సో analgesic nephropathy lead to distal renal tubular acidosis. Autoimmune conditions like SLE may renal involvement lead to distal RTA. And any congenital anomaly is leading to obstruction of urinary tract, like uretero-pelvic junction obstruction, also lead to distal RTA. And distal RTA may there is an increased risk of calcium phosphate kidney stones. Finish this much, you understood? You are done. Then comes proximal RTA. Proximal RTA is more or less similar to our Fanconi. Fanconi is that only, we started that today morning, first topic. Fanconi also lead to, proximal RTA also lead to low serum potassium levels. ये देखेंगे क्यों. First, Fanconi's may bicarbonate is lost into urine. Will you agree or not? Sorry, proximal RTA may agree or not? Proximal tubule is important for bicarbonate reabsorption, amino acid reabsorption, and glucose reabsorption. So there is a bicarbonatenuria. And sodium is normally reabsorbed along with bicarbonate. So if bicarbonate says, I am not going to reading room, I am going to movie, what will sodium will do? It will also go to movie. So bicarbonate lost, along with that sodium lost. That's the reason, sodium is not reabsorbed in proximal tubule. And sodium reaches the distal nephron, because it is not reabsorbed in the proximal tubule. Why it is not reabsorbed? Because bicarbonate is not reabsorbed. So what will distal nephron will do? Ayyo, uppu is all going into urina. That means what? Challi, emainde niku proximal convoluted tubule ko badi didi ne phone karega, distal convoluted tubule. नहीं नहीं, ये बाइकार्ब मेरा बात नहीं सुन रहे, सोडियम भी सुनना बंद कर दिया, दोनों बच्चे मुझे छोड़ के जा रहे. Then immediately what will it do? Peddamma, what will it do? Hey, sodium, don't go. It will try to reabsorb the sodium. But to reabsorb the sodium, what is the only mechanism distal convoluted tubule knows? एक सोडियम लिए तो एक पोटेशियम खो जाएगा. So that is the reason it will cause potassium to lose for every sodium ion reabsorb. Understand? And because of that, there is a loss of potassium into urine, and that leads to hypokalemia. No objection, Your Honor. Then comes the moment there is a bicarbonate in urea and loss of sodium, that will stimulate renin-angiotensin system. And that is final explanation for everything in the world. Renin-angiotensin cause high aldosterone. Aldosterone will cause once more sodium retention and K plus loss into urine. Right? So that is another way to explain hypokalemia in case of proximal RTA. Then comes next. There is an increased risk of hypophosphatemic rickets in proximal RTA. Anyway, this is easy to understand. Why? Because proximal tubule is important for amino acid reabsorption, bicarbonate reabsorption, glucose reabsorption, phosphate reabsorption. The moment there is a phosphaturia, phosphate is not reabsorbed in proximal convoluted, renal tubular acidosis. Phosphaturia will lead to bone cannot grow without phosphate. That's the reason there is a development of mineralization of the matrix doesn't occur unless phosphate and calcium and vitamin D are available. Right? That lead to hypophosphatemic rickets. There you have calcium phosphate stones in distal RTA, and proximal RTA you have hypophosphatemic rickets. Right? Then, how is the urinary pH here? Here there is no problem of secreting H plus into urine to compensate acidosis. There's a reason urine pH can be less than 5.5 in proximal RTA. But urine pH is always alkaline and more than 5.5 in distal RTA. That much you understood, right? No confusion. That is the main differentiator. Entrance mein wahi puchte. How is the urinary pH in proximal RTA versus distal RTA? Distal RTA lo, it can't acidify the urine. And because urine eppudu alkaline untadi, pH more than 5.5. Whereas proximal RTA lo, still the distal tubule is capable of secreting the H plus. That is the reason urine pH can be acidified. Urine pH can be less than 5.5. Common confusion every student ki proximal RTA means bicarbonate in urea. Bicarbonate in urea means urinary pH is should be alkaline anukuntaru. Khadu. So మీరు ఏం చేస్తారు? You ask your examiner. वो तो मैं बताता हूँ, फैंको नहीं है ना, वो छोटा मोटा बात है. तो पहला बताओ, यूरिन pH will be less than 5.5 more than 5.5 in the proximal RTA అని అడగండి. చాలా చిన్న క్వశ్చన్ ఇది అని అన్నాడు అనుకోండి మీ పీజీ ఆర్ అసిస్టెంట్ ప్రొఫెసర్. ఏమన్నదమ్మా ప్రాక్సిమల్ ఆర్టీఏలో బైకార్బోనేట్ ఇన్ యూరియా ఉంటాయి కదా, యూరిన్ pH ఈజ్ ఆల్కలీన్ అన్నాడు అనుకో, అయిపోయా, పప్పుల కాలేషన్ గుడ్డిలింగం. రైట్? మీకు అర్థమైంది పాయింట్ అక్కడ? ప్రాక్సిమల్ ఆర్టీఏ ఉంది కదా నాన్న, ప్రాక్సిమల్ ట్యూబ్యూల్ పనిచేయకుంటే బైకార్బోనేట్ ఈజ్ లాస్ట్ ఇన్ టు యూరిన్. సో డోంట్ థింక్ యూరినరీ pH will be alkaline because of that. Why? Because in proximal RTA, still distal tubule is functioning. Hence, it secretes the H+. That's the reason the urinary pH is no more alkaline, even though bicarb is there. This acidification of the urine done by the distal tubule will cause pH of the urine to become less than 5.5. Whereas in case of distal RTA, never the H plus is secreted. Hence, urinary pH is alkaline in distal RTA. ఇది ఈ ఫండా గుర్తుండాలి. So when you study in reading room, no, why do we go to reading room? Not to study, to threaten the tranquility and peace in our classmates. ఏ నీ ముఖానికి అసలు డిస్టల్ ఆర్టీఏ ప్రాక్సిమల్ ఆర్టీఏ తెలుసా అని మొదలు పెట్టాలి. ఫ్యాంకు నేను విన్నావా నీ జన్మలో అట్లా మొదలుపెట్టి చివరికి వాడు నేను చదవంటారు నాకు చదవద్దని పారిపోవాలి. అయిపోయి ఒక కాంపిటీషన్ 2,50,000 ఇట్ బికేమ్ 2,49,999 కాంపిటీటర్స్ ఇన్ ఎంట్రన్స్. మేము ఇట్లా దిమాగ్ తినేది ఎవరిని సీనియర్లు అని చచ్చేటోళ్ళు వాళ్ళు ఏది మేము రీడింగ్ రూమ్ పోతున్నాం అంటే మళ్ళా పోస్ట్ కొట్టడానికి ఒక హారిజన్ తీసుకుపోయేది. బికాస్ దట్స్ ఓన్లీ వే యూ కెన్ ఇంప్రెస్ ద గర్ల్స్. మై హారిజన్ చదవాలంటే ముందు ఇంగ్లీష్ రావాలి. మా అంతా తెలుగు మీడియం బ్యాచ్, రైట్? సో కమాన్, ప్రాక్సిమల్ ఆర్టీఏ, క్విక్లీ టెల్ మీ 5 points. Defect in proximal tubules, bicarb reabsorption. Urine can still be acidified by alpha intercalated cells in the distal tubule. That's the reason urine pH can be less than 5.5, right? Then serum potassium is low. Now what lead to proximal RTA? There can be Fanconi syndrome. Multiple myeloma can cause proximal RTA. Favorite question. Amphotericin B poisoning lead to distal RTA, but multiple myeloma lead to proximal RTA. Outdated tetracyclines lead to Fanconi, which is more proximal. Similarly, carbonic anhydrase inhibitors like acetazolamide. Diamox is the brand name of the acetazolamide tablet. So, carbonic anhydrase inhibitors also affect the proximal renal tubule. Yeah.
So just now we discussed why distal artery is hypertension.
Post lunch.
Yes, actually, I had a doubt.
Bolo.
Sir, as there is
So Mubin is discussing why hypokalemia will be there in distal artery. Bolo beti.
Sir, as there is a compensation here, sir, because as proximal convoluted tubule is not acting, the compensation is taken by distal.
Correct.
In the same way, as distal is not working here, DCT can take up the function also because Na plus K plus exchange is there.
On.
So there will be hyperkalemia, but because of the overaction of DCT, there's exchange of potassium and reabsorption of sodium.
I'll come back. Why hypokalemia will be there? Don't worry.
No, I'm asking
More clearly.
whether this
आपका क्वेश्चन समझ में नहीं आया. बोल.
This is the thing, sir.
हाँ.
See, normally sodium is reabsorbed.
In movies, have you seen courtroom movies? Advocate will come closer to judge. Let's talk. Yeah.
Sir, sodium is reabsorbed and potassium is excreted in DCT. But problem is here that sodium is not getting reabsorbed and
Ekada?
potassium
Distal
Distal
convolutional. Okay.
Sir, sodium is not getting reabsorbed and potassium is not getting excreted. That means potassium is in the cell, like
It should be retained in the plasma.
So there is hyperkalemia.
That is what our doubt was.
There should be hyperkalemia, but there will be a compensatory mechanism, I guess, in the DCT.
I see you guessed.
No, I'm asking.
Great discovery.
No,
Vakil sahab, great discovery. आप बताएंगे.
as a part of compensation, sodium should be reabsorbed and potassium should be excreted in the DCT.
I mean, your imaginary answer is probably correct, but I'll reconfirm that. मैं वही check करके बताता हूँ. Suddenly I too got a doubt now why hypokalemia. When the distal convoluted tubule is the main site of potassium, there must be some other mechanism which will strongly explain why the hypokalemia is there in distal RTA. I'll come back to that. All right. So, what are the causes of proximal RTA? Quickly summarize. Fanconi syndrome, multiple myeloma, carbonic anhydrase inhibitors. Why carbonic anhydrase inhibitor? What is carbonic anhydrase function? H2O plus CO2 is equal to H2CO3 broken down into H plus and HCO3 minus. So for generating HCO3 plus H plus from H2CO3, you require carbonic anhydrase. So any inhibition of the carbonic anhydrase, what will it do? It won't let bicarb reabsorption to occur because bicarb combines with H plus to form H2CO3, na? Right? So then that H2CO3 in turn is converted into H plus and CO2. That's how the bicarb reabsorption process in the proximal tubule is created. The moment you give carbonic anhydrase inhibitor, bicarbonate cannot be captured in the form of H2CO3 for it to get reabsorbed. That's the reason bicarb is lost into urine. That's the reason carbonic anhydrase inhibitors lead to also bicarbonate and proximal renal tubular acidosis. And there is a hypophosphatemic rickets. Already we answered. Now comes the type 4 RTA. Type 1 RTA, type 2 RTA are hypokalemic renal tubular acidosis. But the only renal tubular acidosis which is not hypokalemic but hyperkalemic is type 4. Now what is the main problem in type 4? You all know juxtaglomerular apparatus, right? Assume this became hypoplastic. If it becomes hypoplastic, there is a decreased renin. Because of that, there is a decreased aldosterone. Normally, what will aldosterone will do? Retention of sodium and loss of K plus, loss of H plus into the urine. If the aldosterone is not there, K plus H plus cannot be lost into urine. They will be collected in the, accumulate in the blood. Hence, accumulation of potassium lead to hyperkalemia. Accumulation of H plus leads to acidosis. Maladdama? Juxtaglomerular apparatus hypoplasia leads to decreased renin, decreased angiotensin, decreased aldosterone. If aldosterone is not there, K plus H plus secretion doesn't occur into urine. So K plus H plus retained in the blood. That lead to hyperkalemia and acidosis. Still any doubt? Anybody? మీకు అర్థమైందన్న యువర్ సార్ అర్థమైంది చెప్పాలి లాస్ట్ పార్ట్ ఓకే గుడ్ ఐ ఆల్వేస్ రిలీష్ ఆషియాస్ కామెంట్ ముందు అసలు బయోస్థిరిక్ రివ్యూస్ అంటేనే ఏదో తెలియదు మళ్ళీ మీరు దానికి డిటిఆర్ ఇంక్రీజ్ అవుతుందా డిటిఆర్ నార్మల్ ఉంటుందా గుడ్ దెన్ ఐ అండర్స్టూడ్ ఫస్ట్ ఐ నీడ్ టు టెల్ దట్ ఇగోమ్మా ఆల్డోస్టిరాన్ ఉంటుందా ఆల్డోస్టిరాన్కి ఒక ఫంక్షన్ ఉంటుంది ఏంటది ఎపిథీలియం సోడియం ఛానల్ దగ్గరికి వచ్చి ఈఎన్ఏసి అంటారు ఇట్ విల్ కాజ్ ద రిటెన్షన్ ఆఫ్ సోడియం ఇన్ టు ద బాడీ ఆ ప్రాసెస్లో అది ఏం చేస్తుంది ఎక్స్చేంజ్ చేస్తుంది ఏంటది హెచ్ ప్లస్ అండ్ కే ప్లస్ని tubular fluid loki, which is lost into urine. So, if aldosterone is not there, sodium is not reabsorbed. Sodium is not reabsorbed. Hence, H plus K plus will not go into urine. Idi it rakunda vatubo. Then H plus and K plus will remain in plasma, not urine, plasma. That's the reason there is a acidosis and H plus retention lead to acidosis, K plus retention lead to hyperkalemia. Still ఎవరికైనా అర్థం కాలేదా మళ్ళీ ఫస్ట్ పార్ట్ నుంచి చెప్తా juxtaglomerular apparatus aplasia leads to low renin because juxtaglomerular apparatus produce renin. Low renin, low aldosterone leads to no secretion of H plus K plus, leads to H plus K plus retention, leads to acidosis and hyperkalemia in case of renal tubular acidosis type 4. What is responsible for this hyporeninemic hypoaldosteronism leading to hyperkalemic acidosis? Diabetic nephropathy. Very, very, very common. Right? Then one more important point. How will be urine pH here? ఒక రకంగా చెప్పాలంటే problem in what type 4 RTA ఎక్కడుంది ప్రాబ్లము? డిస్టల్ ట్యూబ్యుల్లోనే ఉంది. కానీ డిస్టల్ ట్యూబులార్ ప్రాబ్లమ్ ఆఫ్ సెక్రీషన్ ఆఫ్ H+ ఉంటే యూరిన్ pH ఏముండాలి? ఆల్కలీన్ ఉండాలి. కానీ ఇక్కడ యూరిన్ pH will be less than 5.5 ఎసిడిక్. ఎందుకు అనంటే whenever there is an acidosis in the body, how will what are we talking now? Why the urine pH is less than 5.5 or variable, right? So fundamentally in type 4 RTA, what is the problem? Hypoaldosteronism. That is leading to what? Retention of potassium and reduced potassium excretion. Now what is the effect of hyperkalemia? ikkada in the story. Hyperkalemia ko ek effect hai. Kya hai? It will inhibit the ammonia production. It will affect the ammonia production, reducing the ammonium excretion. How is H+ excreted into the urine? Not simply like H+. How is it excreted? NH3 plus H+ will form NH4+, and NH4+ is lost into urine. Who provides that NH3? Glutamine converts into glutamate and release NH3. That NH3 binds with H+ to form ammonium ion, NH4+, which is lost into urine. That's how glutamate is very important. Glutamate is very important. Why? Because glutamate becomes glutamine, and glutamine will provide ammonium and reconvert into glutamate. Ammonium, NH3 will bind with H+ to lead to NH4+, and that is lost into urine. So this ammonia production process ko hyperkalemia inhibits. And what will happen? That limits the removal of acid. But if the ammonium is not there, ammonium production is interrupted, the secretion of the H+ will get affected. Then what should happen to urinary pH? It should become alkaline only, no? It is not explaining why urine pH can still be less than 5.5. This we will come back with this. This also will keep under deeper review. Okay? So all these are what some mechanism. But summarize. Proximal RTA, how is urinary pH? Less than 5.5, because distal tubule is still working. Distal RTA, how is the urinary pH? Alkaline. And how is the urinary pH in case of type 4 RTA? It is variable, but generally pH is less than 5.5. Hypokalemia is a feature of type 1 and 2 RTA, but not type 4 RTA. Hyperkalemia of type 4 RTA is explained because of the hypoaldosteronism. Where do you get hypophosphatemic rickets? మళ్ళీ ప్రాక్సిమల్ డిస్టల్ చెప్పుకుందాం, ఇది ఈజియర్. ప్రాక్సిమల్ ఆర్టీఏ. Where do you get calcium phosphate stones? In case of distal RTA. Distal RTA, which is type 1. సరిపోయిందా? మస్తు ఇది తెలిస్తే చాలు. ఇటియాలజికల్ ఫ్యాక్టర్స్ కూడా కొంచెం లాస్ట్ మూమెంట్లో ఒక పారాగ్రాఫ్ ఉంటుంది రివిజన్. పరీక్ష ముందు ఒక్కసారి ఆ ఇటియాలజికల్ ఫ్యాక్టర్, దేంట్లో స్టోన్ ఫామ్ అయితే దేంట్లో ఫ్యాంకరీ ఉంటుంది, అది తెలిస్తే యు ఆర్ సూపర్ కింగ్. And also you should know what are all the conditions leading to type 4 RTA. Diabetic nephropathy, common cause. ACE inhibitors, angiotensin receptor blockers. Enduko ACE inhibitors, angiotensin receptor blockers will affect the renin-angiotensin system and aldosterone levels. Understand? NSAIDs, I told you, lead to hyperkalemia. One of the reasons for NSAIDs leading to hyperkalemia is by creating type 4 RTA situation. Type 4 RTA situation. Did I tell NSAIDs in any other renal tubular acidosis? Cheppinama inta mundu etiology dentlo type somewhere we said underlying cause is NSAID, no? Huh? Type 1 or type 2? అక్కడ చెప్పుకున్నాం కానీ ఈ ప్రాక్సిమల్ డిస్టల్ లే కదా, ఎందుకంటే అవన్నీ హైపోకెలీమియా కాజింగ్, ఇదేమో హైపర్కెలీమియా కాజింగ్. సో ఎన్ఎస్ఐడ్స్ లీడ్ టు విచ్ టైప్? టైప్ 4, రైట్? దెన్ heparin. Where do we use heparin such a long time that it will lead to type 4 RTA leading to acidosis and hyperkalemia? Pregnant women, if they are having any deep vein thrombus, you can't give in the first trimester warfarin. That's the reason what we do, we give heparin almost for 3 months. Then second trimester aate hi we convert back into warfarin, and before delivery once more we convert into heparin. So such long heparin takers may be, sometimes there can be distal, type 4 RTA. Similarly, cyclosporin, which is used for renal transplant patients as immunosuppressive, is also type 4. Similarly, adrenal insufficiency like Addison's disease. What will happen in adrenal insufficiency? There are no glucocorticoids, there are no mineralocorticoids also. That means there is no aldosterone. Any low aldosterone is a thing that lead to type 4 RTA. And any potassium sparing drug like spironolactone, it is aldosterone antagonist. Simple Bactrim DS, trimethoprim sulfamethoxazole that you give for pneumocystis carinii pneumonia prophylaxis in HIV patients also can lead to type 4 RTA. And any obstructive nephropathy can lead to type 4 RTA is what you need to remember. ఇవన్నీ కూడా లాజికల్ టాపిక్స్ ఆన్ నెఫ్రాలజీ. మిగతా అంతా రామాయణం, రైట్? సో ఫటాఫట్ ఖతం కరెంగే. టుడే ఐ డిటర్మైన్ టు ఫినిష్ బిఫోర్ లంచ్, not to leave anything. Casts in urine. What is urine called as? Complete urine examination called as poor man's renal biopsy. एक गरीब आदमी renal biopsy के लिए पैसे नहीं दे पाए तो उसका complete urine examination करे तो भी उसमें बहुत कहानी बाहर निकलेगा. इसलिए complete urine examination is called poor man's renal biopsy. Now, first, different casts in urine. So whenever there is a bladder cancer or kidney stones, there will be hematuria but no casts. Acute cystitis, bladder inflammation, will lead to pyuria, pus cells in the urine, but no casts. If there are RBC casts in the urine, what does it mean? Glomerulonephritis or any hypertensive emergencies when kidney is affected with high blood pressure, that can also lead to hematuria and RBC casts. And always remember, whenever you have an RBC hematuria, how do you know whether hematuria is originating from glomerulus or it can originate from the what? Ureter or from the bladder or from the urethra. Indulo up to glomerulus you call upper urinary tract, and below that you call lower urinary tract. Any bleeding coming from the lower urinary tract will lead to biconcave disc-shaped RBCs which are normal shape. Whereas anything originating from the glomerular pathology will lead to dysmorphic RBCs. So dysmorphic RBC, normal morphology is what? Biconcave disc. Dysmorphic RBCs is an indication of upper urinary tract. Glomerular origin is what you need to remember. Then when do you get WBC casts? White blood cell casts. Pyelonephritis, transplant rejection, tubulointerstitial inflammation. किडनी में क्या होता है? खाली तीन चीजें होती है, ग्लोमेरुलस होता है, ट्यूब्यूल होता है, बीच में इंटरस्टिशियम रहता है. इंटरस्टिशियम में मिसेंजियल सेल्स रहता, मिसेंजियल मैट्रिक्स बनता, बस इतना ही रहता. इसी में ग्लोमेरुलस है तो ग्लोमेरुलोनेफ्राइटिस, ट्यूब्यूल है तो ट्यूबुलर इंटरस्टिशियल. Tubule अकेला नहीं होता unless in ATN or acute tubular necrosis, right? So tubulointerstitial inflammation, acute pyelonephritis. What do you mean by pyelonephritis? Minor calluses, major calluses है ना किडनी में. So वो calicial inflammation is called pyelonephritis. Pyelonephritis. इसमें क्या होता है? WBC casts. Then granular casts. There are casts in the urine which are granular. इसको बोलते हैं angry urinary sediment. Angry urinary sediment. मतलब किडनी बहुत नाराज गुस्से में है. Granular casts. Granular casts are an indication of acute tubular necrosis. And they can be muddy brown in color, will be the granular casts. Then fatty casts, nephrotic syndrome में, because nephrotic syndrome में there is a lipiduria, proteinuria that lead to fatty casts. In that you get what is called Maltese cross sign. Maltese cross sign because of the fatty casts and lipiduria. Then you have waxy casts when the end stage renal disease is there. किडनी गया, पूरा किडनी स्मॉल हो गया, स्क्लेरोटिक हो गया. इसमें क्या होता? tubules become dilated. So any cast formed will be broad waxy cast, it is called as, in chronic kidney disease. Okay. Then normally any person dehydrated can have casts which are hyaline casts, is a normal finding. Normally only renal tubules produce a protein called Townes-Harsfeld protein, and when that gets secreted excessively, especially when there is a severe urinary tract infection, that lead to formation of hyaline casts which can even be normal finding. फटाफट देखेंगे casts को. Hyaline casts in a wet preparation. What is this? Hyaline casts are the feature of what? Normal urine में. These are called granular casts, which are angry urinary segment, which is in pyelonephritis. In tubulointerstitial inflammation. Okay. Then these are the WBC casts, which are seen in acute interstitial nephritis. What is the meaning of that? Only matrix and interstitium are infiltrated with WBCs is called interstitial nephritis. So there is one glomerulonephritis. There is a tubulo-interstitial inflammation or only interstitial nephritis or only tubular damage, or there can be pyelonephritis. నాలుగే ఉన్నాయి వీళ్ళకి, నెఫ్రాలజిస్ట్లకి. ఏమేంటి? గ్లోమెరులోనెఫ్రైటిస్, pyelonephritis, interstitial nephritis, and tubulo-interstitial inflammation and acute tubular necrosis. Bas. Nephrology, cheap chitka subject of all, but most important subject. ఎందుకు? నెఫ్రాలజిస్ట్ అయితే ఎక్కడ ప్రాక్టీస్ స్టార్ట్ చేయాలి తెలుసా మీకు? Which district is called rice bowl of India? नेल्लूर मा ऊरू. नेल्लूर में पूरा राइस पैडी पैडी पैडी. మార్నింగ్ లేస్తే ఇడ్లీ, మధ్యాహ్నం ఇడ్లీ, రాత్రి దోశ, మళ్ళా మిడ్ నైట్ ఆకలేస్తే ఇంకా కొంచెం రైస్లో పులిహోర, మళ్ళీ ఎర్లీ మార్నింగ్ ఆకలిస్తే కదమ్మా బ్రేక్ఫాస్ట్ ముందు 4:35కి, అప్పుడు కూడా లేచి పెరుగన్నం, చద్దన్నం, రైస్ రైస్ రైస్. సో రైస్ will lead to diabetes, diabetes lead to diabetic nephropathy, diabetic nephropathy lead to dialysis dependence. Dialysis dependence is where you buy the new Mercedes E-Class as a nephrologist. So you want to be a nephrologist, go to Nellore, go to Guntur, go to Vijayawada, etc. etc. Telangana में क्या है? Fluorosis. Nalgonda में. So you want to be bone specialist, neurosurgeon, Telangana. Good. Then comes Maltese cross. What is this called? Maltese cross, which is the feature of lipiduria in nephrotic syndrome. Finish. Now comes glomerular diseases. Assal शेर बाहर निकला. फटाफट खत्म करेंगे. ग्लोमेरुलर डिसऑर्डर्स का क्लासिफिकेशन, नॉमेनक्लेचर क्या होता? फोकल, डिफ्यूज, प्रोलिफरेटिव, मेम्ब्रेनस. Focal means what? Less than 50% of glomeruli are involved, just like in focal segmental glomerulonephritis. Diffuse means more than 50% of the glomeruli, like diffuse proliferative glomerulonephritis, DPGN. Then proliferative glomerulonephritis, that means the glomeruli are studded with the cellular infiltration, hypercellular glomeruli. Cellularity can increase or cellularity can be normal in glomeruli. Cellularity बढ़ गया तो hypercellular glomeruli, which is called membranoproliferative glomerulonephritis, is one example. Then membranous glomerulonephritis, glomerulus में क्या होता है? Bowman's capsule. Inside that you have the glomerulus. So glomerulus में glomerular basement membrane जो होता है वो thickened हो जाता, इसको कहते हैं membranous nephropathy. Clear terminology? So what is this called? Focal segmental. Focal because less than 50% glomeruli involved. And all this is what? Sclerosis. Fibrosis is sclerosis. Sclerosis. Focal segmental glomerulosclerosis का histology is like this. So it's a normal glomerulus है तो there is a scar which is forming, leading to impaired kidney function को क्या बोलते हैं? Focal segmental glomerulosclerosis. Here more than 50% glomeruli are involved. Diffuse proliferative glomerulonephritis. So this is the endothelial cell, this is the basement membrane, this is the epithelial cell. Fundamental architecture of our glomerulus, right? And when antibody meets antigen, it forms an immune complex and comes and deposits along this membrane and lead to thickening of the glomerular basement membrane, which is typically called membranous nephropathy. So this is a normal glomerular capillary wall with thin walls. Whereas this is a membranous glomerulopathy with a thick capillary wall. Now coming to glomerulopathies. How do they present? They can present with nephritic syndrome, nephrotic syndrome, and nephritic syndrome. Nephritic syndrome क्या होता है? There is a inflammation of the glomerulus leading to glomerular basement membrane discharge damage. Because of that, the RBCs are lost into the urine, and they are dysmorphic RBCs found in the hematuric sample in nephritic syndrome. So there is a hematuria, RBC casts in urine, there is a decreased glomerular filtration rate. Because the decreased glomerular filtration, there is oliguria, azotemia. Azotemia means creatinine, urea getting accumulated is called as azotemia. NPN substances means non-protein nitrogenous substances accumulation, urea, creatinine. There is an increased renin in the patients who have nephritis. Increased renin will lead to increased aldosterone, lead to increased sodium retention, lead to hypertension. And in this nephritic syndrome also there is a proteinuria. But proteinuria is subnephrotic range, less than 3.5 grams per day. So what are all the conditions that lead to nephritic syndrome, doctor? Post-infectious, that is post-streptococcal glomerulonephritis, PSGN. Coca-Cola colored urine. Like a Coca-Cola, if you say Coca-Cola colored urine, bus, examiner says you are passed. So then comes good pasture syndrome. The glomerular basement membrane is there, no? There are antibodies directed and go and injure it. You all attended vasculitis class, no? Some of you, hopefully. Then IgA nephropathy. ये भी हमने discuss किया. What is the difference between post-streptococcal glomerulonephritis and IgA nephropathy? रात गई और बात गई. सोर थ्रोट आने के बाद पेशाब जा रहे तो हिमैचुरिया हो गया. सोर थ्रोट आने का 72 आवर्स में हिमैचुरिया आ गया तो IgA nephropathy. सोर थ्रोट के बाद 3 हफ्ते के बाद PSGN, that's the reason IgA nephropathy is called synpharyngitic hematuria. Syn, S-Y-N, not S-N. S-Y-N. Synpharyngitic hematuria. And it is the most common cause of the recurrent benign hematuria. Every time he gets upper respiratory infection, every time he gets hematuria, but it is subsiding. It is not leading to chronic kidney disease. Hence it is called benign recurrent hematuria. మీరు ప్రాక్టీస్లోకి పోతే రోజు ఉంటారు దవాఖానలో బర్జర్లు IgA నెఫ్రోపతిలు గ్లోమెరులోనెఫ్రైటిస్లో అట్లా లైన్గా కూర్చుని ఉంటారు. దెర్ ఇస్ నో ఎనిగ్మా అబౌట్ ద కండిషన్స్ దట్ వీఆర్ స్టడీయింగ్. బట్ మీరు అడగాలి ఎవరిని, సీనియర్స్ని, అన్న ఒక్క IgA నెఫ్రోపతి చూపించు, ఒక్క కేస్ ఆఫ్ ఏ హాస్పిటల్ అయినా పర్వాలే. ఇవాళ వాట్సాప్లో వీఆర్ ఆల్ కనెక్టెడ్ ఎనీవేర్, నో? Anyway, right? In our days, there used to be no ఈకోకార్డియోగ్రామే ఉస్మానియాలో ఉండేది, గాంధీలో కూడా ఉండేది కాదు. నాకు ఇంకా గుర్తు, ఎల్లమంద అని ఒక పేషెంట్ ఉండే. అది mitral stenosis or mitral regurgitation. Mitral stenosis or regurgitation. We had an argument in the ward. I was in అప్పుడు థర్డ్ ఇయర్ MBBSలో ఉండే. We used to have one very nice teacher by name Dr. Kundal Rao. He's a cardiologist now in Yashoda, Secunderabad. Senior cardiologist. Very loving teacher. We learned ECG from Dr. Kundal Rao sir. We all used to be there in New Boiguda hostel in Gandhi. So sir was doing DM that time. అప్పుడు me and my friend Gangadhar, we went by bike, taking Elemanda, triple market. New Boyguda to Usmania. There we used to have a 2D commission. Just because I was not agreeing for a loud S1 in that case. Right? Because my friends are listening loud S1. How can I not listen loud S1? Why Elemanda is having really MS or MR was the doubt. So I still remember. Whenever we meet, we remember those days. సో అప్పటికప్పుడు 2Dకి వచ్చేసి ఈసీజీ రివ్యూ చేసిన తర్వాత సార్కి ఎలమంద గారికి ఎంఎస్ ప్లస్ ఎంఆర్ ఉంది, అందుకోసమే లౌడ్ S1 ఇనస్తలేదు అనే విషయం ప్రూవ్ చేసిన. Your intellectual curiosity should be beyond boundaries and borders, beyond rules and imagination. Nobody, once we become 18, will tell us to become great. Only 18 వరకే మనకి ఎవరైనా అమ్మా నాన్న ఎవరో చెప్తారు, అరే నువ్వు గ్రేట్ కావాలి రాదు కావాలి. ఆఫ్టర్ దట్ అవర్ ఇకోసిస్టమ్, అవర్ కండిషన్స్, అవర్ ఇంటర్నల్ ఫైర్ should make us to become something in life. Remember that. Okay? So that's the reason until 18 లోపల కనుక కాంట్రిబ్యూట్ చేయకపోతే we can blame parents. 18 కూడా too long. 14 తర్వాత as parents we are not responsible for whatever children will become. They become drug addict, they can become anything in life they want. Right? So what I'm saying is all these cases are there in the hospital. Take chance to do the revision. So membranoproliferative glomerulonephritis, all this will lead to nephritic picture. So what are these, doctor? These are a bunch of dysmorphic RBCs in urine. Then what is nephrotic syndrome ka story kya hai? Simple. Bowman's capsule hai na? Then in the glomerulus, you have in the Bowman's capsule mein visceral epithelial cells and parietal epithelial cells and rendu untai capsule ki. Ee visceral epithelial cells ki you have podocytes, food processes. They act like a slit to prevent protein oozing into the tubular fluid. The moment that podocytes are lost, there are no negative charges available to stop a negatively charged molecule called albumin going into urine. That's the reason the loss of the negative charges, because the loss of the podocytes will lead to loss of albumin into the urine, which is responsible for nephrotic syndrome. In nephrotic syndrome, there is a massive proteinuria, that is protein levels are more than 3.5. And there is a hypoalbuminemia, low albumin. And you know, how is lipid carried in our body? Lipoproteins. Right? What is the principal carrier of cholesterol? LDL. Principal carrier of triglyceride? Endogenous VLDL. Exogenous chylomicron. They're all lipoproteins. They have a lipid carried by a protein moiety. The moment there is a proteinuria, there is no apoprotein available, hence the lipids cannot be handled, and that leads to development of hypercholesterolemia in the patients who have nephrotic syndrome. Also, antithrombin 3 is lost into urine among the various proteins. Antithrombin 3, what does it do? It will go and inactivate the thrombin. What is thrombin? Activated factor 2 is called thrombin because factor 2 is prothrombin. Got it? So if the antithrombin 3 is not there, there is nobody to inactivate factor 2A, which is thrombin. That leads to hypercoagulable state. A patient of nephrotic syndrome comes with a swollen leg because of the presence of the deep vein thrombosis. Similarly, immunoglobulins are lost into urine. That's the reason there is an increased risk of infection. Now, what are the examples of nephrotic syndrome? Minimal change disease is the most common cause of nephrotic syndrome in children. Membranous nephropathy is the most common cause of nephrotic syndrome in adults. And focal segmental glomerulosclerosis, we have seen no, just before. That also lead to nephrotic syndrome. Amyloidosis involving the kidney, nephrotic syndrome. And our favorite, diabetes. Diabetes में क्या होता है? न्यूरोपैथी होता, रेटिनोपैथी होता, नेफ्रोपैथी होगा, बाद में तिरुपति. Right? So, diabetic glomerulopathy. Once diabetes is detected, why you will ask patient to get every 6 months investigations done? Because every 6 months we want money. Right? The diagnostic guy will send you the money. Sir, your full checkup, 10,000 rupees, so your 5,000 rupees comes to your account. Because you need to monitor whether your diabetes patient who is detected with diabetes is having hyperlipidemia, proteinuria. How is it in control? You need to monitor. Understand? So, agar seat time mile to na, I'll tell you one secret. Don't just waste time in preparing for entrance. Daddy को बोलो एक अच्छा कमरा find out करो, clinic लगाओ. Fellow of Indian College of non-postgraduate or otherwise postgraduate preparing MBBS student. Postgraduate, no, what is that? Indian Fellow of Indian College of Post NEET PG preparing student, no? NPS, F, Fellow of Indian College, FIC, Fellow of Indian College of NEET PG, N, preparing P, S means, A means aspirant. I am FIC and CAP is what you tell you. Sir, पेशेंट आपको पूछेगा ये एमआरसीपी की बात करते हैं सर. हाँ, इट्स अ वेरी हाईली रेटेड डिग्री, राइट? सो आई विल बी प्रेसिडेंट ऑफ दैट and all entrance preparing students will give a admission. Understand? So क्या है ना, एक अच्छा डायग्नोस्टिक लैब वाले को आके बैठने के लिए बोलो. You put diabetes, fever, BP expert, diabetologist, feverologist and BPologist. हाइपरटेंशन बोले तो उनको समझ में नहीं आता, इसको बहुत टेंशन है. वो सोचेगा कि इसको बहुत टेंशन है बोल के हाइपरटेंशन नको बोलना. बीपीओलॉजिस्ट, feverologist, painologist and diabetologist. Finish these 4 things. If you know to manage, no doctor, आपके बच्चे इंग्लिश मीडियम स्कूल को भिजाने के लिए जो भी पैसे चाहिए वो मिल जाएगा, कारोबार चलेगा. That's the reason. So now let's talk. Nephritic, nephrotic, दोनों. एक तरफ प्रोटीन जा रहे हैं, दूसरी तरफ ब्लड भी जा रहे हैं. Hematuria भी है, hypertension भी है, nephrotic range proteinuria भी है. Where do you get that? 2 conditions: diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis. Main thing, hypertension, hematuria is equal to nephritic. Proteinuria, lipiduria, hyperlipidemia, prothrombotic state, all is nephrotic. Khatam? No. Let's start with PSGN. What type of hypersensitivity is the immune complex deposition? Correct. Type 3. Every time immune complex formed, every time idli is consumed, chutney also is over. So complement is consumed every time immune complex formed. So hypocomplementemia is the characteristic feature of PSGN. But one important point. Complement level will be low in PSGN, but within 6 weeks that will normalize. If it did not normalize and complement continue to be low, then it is not PSGN. అది ఇంకొక రూల్ ఉన్నది. వాట్ డాక్టర్ ఫైన్ దిగులు పడ్డది. ఇవన్నీ రెండోసార్లు చదువుతుంటే అన్నీ వచ్చేస్తాయి. ఎంట్రన్స్ అయినా ఇవన్నీ మర్చిపోవాలి మళ్ళీ. అది ఇంకొక ప్రాసెస్. అంటే మర్చిపోతాంలేండి, ఎందుకంటే పీజీ చేసేటప్పుడు పీజీ హోతా హై గధా. ఇట్రా పోయి ఆడ బ్లడ్ శాంపిల్ పట్టుకురా, ఆడ డిశ్చార్జ్ శాంపిల్ ఎందుకు రాలే. దీనికోసమా నేను చచ్చి 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 చెడి చదివిందని. రైట్? పీజీ ఈజ్ ఆల్ అబౌట్ వాట్? Entire first year is to forget subject. Entire second year is about forget the newly married wife, what she asked you to do or bring home. Final year is all about once more taking out those notes and start reading. Not even Harrison or Davidson. Notes written during entrance time. The same 160 pages is for your MD final year also to pass. Hypocomplementemia is a feature because immune complex deposition disease, but complement will return within 6 weeks to normal. It is a group A streptococcus responsible, and after getting group A streptococcus sore throat, patient get glomerulonephritis 2 to 4 weeks after. Another important point: streptococcus sore throat, streptococcus skin infection, both can lead to, any of them can lead to glomerulonephritis, but rheumatic fever is only because of sore throat, not due to the skin infection causing strains, is what you need to resolve. Remember, a lot of times all that hematuria, all that hypertension that you see with PSGN will resolve spontaneously. Then what are we doing? We are doing urine examination, we are admitting the patient, we are saying we will control the BP. By the time you do all that, it resolves spontaneously. So that is the point you need to remember. So what do you see in light microscopy? Post-terminal glomerulonephritis will lead to hypercellularity and enlarged glomeruli. And if you do immunofluorescence, what will you see? All that immune complexes which got deposited will lead to starry sky appearance. So, if you marry in first year, you may not be able to take your girl to Italy and show in a small hamlet lying down and watching the starry sky. वो सब माइक्रोस्कोप में दिखा सकते हैं. Starry sky appearance. क्योंकि if you do immunofluorescence चमकता है ना, तो इसमें lumpy, bumpy appearance of the glomerular basement membrane because of the immunoglobulins deposited. Which immunoglobulin? IgG, IgM and C3 deposition. Then if you do electron microscopy, right? So the humps are typically formed where subepithelial. So glomerular basement membrane है ना? So you need to know intraepithelial, that is intramembranous deposits, subepithelial deposits. Which type of deposits is a favorite question on electron microscopy in glomerulonephritis. So what will you remember? Yes for streptococcus, yes for subepithelial. So what is this called? A hump, lumpy, bumpy hump. A subepithelial deposit in the glomerular basement membrane in post-streptococcal glomerulonephritis. ये क्या होता है? Lumpy, bumpy, starry sky appearance because of the deposition of the IgG, IgM and C3 along the GBM and mesangium. And how is the glomerulus here? Hypercellular. Because of that hypercellularity of this glomerulus, the entire capillary loop is not well defined. Capillaries nahi na, glomerular capillaries, where blood will come and drain through the Bowman's capsule. This is another example of a hypercellular enlarged glomeruli in PSGN. This once more, the starry sky appearance in case of PSGN. And this is what? The Bowman space is reduced because GBM is all infiltrated with immune complex deposits, there is an increased cellularity in the glomeruli. This is that Coca-Cola colored urine due to nephritis in case of the PSGN. And PSGN also lead to fetal edema. And immunofluorescence in PSGN has got a starry sky appearance. One more example of what? Subepithelial humps seen below the podocytes in a patient who has got PSGN. Ante, ఇవి బొమ్మలు చందమామ స్టోరీ అబౌట్ పిఎస్జిఎన్. ఈ 4-5 పలుకులు గుర్తుపెట్టుకుంటే పరీక్షలో ఎగ్జామినర్ ఖుష్. Then comes IgA nephropathy. What is this? Synpharyngitic hematuria is IgA nephropathy. After a GI tract infection or respiratory tract infection, immediately within 72 hours, if there is a development of hematuria, it is episodic. It will resolve within 2 to 3 days. Why? Because GIT and respiratory tract are what? Mucosal lumen, which secretes secretory immunoglobulin is IgA. And that IgA will get an idea. If IgG, IgM can go and form immune complex and deposit, why not I do that? And it will go and deposit. Where? In the glomerulus. And the moment IgA comes, mesangium is excited, it proliferates. So mesangial proliferation is the hallmark. And where is this IgA deposits are located? They are there in the mesangium. And if you do electron microscopy, what do you see? IgA deposits in the mesangium, not in the GBM. So no GBM thickening. You only see mesangial deposits. So this is how the IgA deposits in the mesangium in IgA nephropathy. Once more, when you stain, you can see nicely IgA deposits in the mesangium is what you need to remember. Khatam? Next comes RPGN. RPGN. The name only says rapidly progressive glomerulonephritis. Today we met, tomorrow coffee shop, third day, Oyo. That's called rapidly progressive glomerulonephritis. Very fastly developing azotemia, uremia is called RPGN. Okay? So kidney will say, honey, I think we are going too fast, let us make it a little slow. But I am RPGN. Right? So what is the main histopathology in RPGN? Crescent. What is that? Crescent. So having had come from Telugu medium background, I used to say in the ward rounds, crescentric. My professor used to say, arey, eccentric ranu. It is called crescentic, not a trick. Crescent. Okay, what is crescent? So basically in the Bowman's capsule around the glomerulus, you are having the visceral epithelium and parietal epithelium. Parietal epithelial cell proliferation. Parietal epithelial cell proliferation exuberantly will cause lot of parietal epithelial cells which come and block the Bowman space. So these proliferating parietal epithelial cells को कहते हैं crescent. They form the crescent. In crescentic glomerulonephritis. అర్థమైందా? What are crescents in crescentic glomerulonephritis? Proliferating parietal epithelial cells. మీరు ఇవాళ పోయి అడగండి, మీ పీజీ చేస్తుంటారు కదా ఎవడో ఒక గుడ్డలింగం, క్రెసెంట్ అంటే ఏందన్నా? హే క్రెసెంట్ అంటే క్రెసెంట్ రా భయ్, క్రెసెంట్ ఇంకేముంటుంది? క్రెసెంట్ అంటే ట్యూబ్యులార్ సెల్ ప్రొలిఫరేట్ అయిందా, పోడోసైట్ ప్రొలిఫరేట్ అయిందా, పెరైటల్ సెల్ ప్రొలిఫరేట్ అయిందా, మిసాంజియల్ సెల్ ప్రొలిఫరేట్ అయిందా, అసలు ఇన్ని సెల్స్ నేను తెలుసారా నీకు అని అడగండి. పెయిడ్ సీట్లు ఉండవు ఇవన్నీ, ₹1,00,00,000 కట్టే సీట్లు ఇవన్నీ ఉండవు. 40-50 లక్షలు కట్టే సీట్ల కొంచెం ఉండొచ్చు ఇవి. ఓకే, crescent is parietal epithelial cell proliferation That is pathology. What nephrologists call it as rapidly progressive glomerulonephritis. Then rapidly progressive glomerulonephritis is divided into three types: pauci-immune, immune complex, and anti-GBM type. How many types? Immune complex, anti-GBM. Pauci-immune मतलब इधर immune complexes नहीं form हो रहे, इसलिए complement levels are normal, and there are no deposits in the immune complex. Deposits are not there. Typically, pauci-immune glomerulonephritis are all ANCA positive. Vasculitis lo ఒకటి వదిలేసి వచ్చినాం కదా Wegener's లో ANCA, P-ANCA, C-ANCA in Wegener, P-ANCA in Churg-Strauss. How many did not attend our rheumatology, hematology class? Rheumatology మంచిగానే అయింది కానీ hematology కొంచెం స్లో డౌన్ అయిపోయింది. ఐరన్ డెఫిషియన్సీ తాలసీమియా దగ్గర కొట్టుకుని వదిలేసిపోయినాం. సరే, సియాంకా దేంట్లో ఉంటుంది? మీరు అందరూ అటెండ్ అయ్యారు కదా, రొమటాలజీకి వచ్చారు కదా. रोमेटोलॉजी पेरेंटम को आ गया ना. हाँ, दशहरा को वो, दिवाली को ये. हाँ, then granulomatosis with polyangiitis is the name given to vagina. Typically lead to pauci-immune RPGN. Example: what is immune complex mediated immune complex deposits, like in lupus nephritis is an example. Then what is anti-GBM disease? It is good pasture, where IgG goes and deposits linearly, is what you need to remember. Now let us quickly talk about RPGN. Number one, RPGN has a poor prognosis because it is rapidly deteriorating within days to weeks. Then on light microscopy, what do you see? Crescents are being found. So crescents, what do they contain? Fibrin, plasma protein, that is complement C3b, with proliferating glomerular parietal cells, monocytes, macrophages which infiltrated. ये सब मिला के क्या बन गया? Crescent. Understand? Then in pauci-immune में there is no C3 deposition, immunoglobulin complement deposition is not there. And what are the examples of that? Wegener's, Churg-Strauss, microscopic polyangiitis, they're all the examples. Okay, ఒక క్వశ్చన్ అడుగుతాను, మీరు ఆన్సర్ తప్పు చెప్తే లంచ్కి వెళ్ళిపోదాం. Polyarteritis nodosa versus microscopic polyangiitis, what is the basic difference? Which involves pulmonary artery, which does not involve pulmonary artery? Edi? Polyangiitis involves pulmonary artery. I told also one way to remember, MPA is microscopic polyangiitis. MPA is also the name for main pulmonary artery. Hence, pulmonary artery involvement is a feature of microscopic polyangiitis, but not polyarteritis nodosa. What is the viral infection found 30% of cases of hepatitis B? And which vasculitis has hepatitis C association? मैं के चली जाऊंगी तू ఆన్సర్ नहीं बोले तो. మీరు ఎట్లా ఉండాలంటే విన్న తర్వాత ఒక్కసారైనా చదవాలండి. నాకు తెలుసు మీరందరూ ఏకసంధాగ్రాఫులు, वन टाइम बोले तो ही ग्रहण कर लेते, मगर टू फॉरगेट इज ह्यूमन. ओके, the common mistake we do is attending Purana Kalakshepa is a way to get mukti and moksha. नहीं मिलता. भगवद गीता पढ़ के इवनिंग जाके झूठ बोले तो कुछ भी नहीं मिलता. प्रैक्टिस करना है गीता को. हाँ, కాబట్టి కొంచెం చదవండి. దెన్ అప్పటికి వాట్సాప్ గ్రూప్లో నేను ఈ మధ్య కొంచెము క్వశ్చన్ వేయడం బంద్ చేసిన, అవి కూడా చూడలేదు మీరు. వాట్ ఐ ఫౌండ్ ఇస్ ఆల్ ఆర్ నాట్ సీయింగ్. వస్తుంది పడుతుంది కదా పండుగ. ఐస్ ए सोशल मेंटल सिक्योरिटी. डॉक्टर मुरली बंदवास को टाइम मिल गया, क्वेश्चन डाल रहे, आंसर के ऑडियो डाल रहे, पहला क्वेश्चन उसका आंसर भी टेक्स्ट डाले, कोई भी नहीं पढ़ रहे, चलो एक्सप्लेनेशन को हाइड करके ऑडियो मंत्र दिया, वो भी नहीं देख रहे, इसलिए डायरेक्टली वीडियो को प्रेजेंट किया. बट अल्टीमेटली यू नीड टू हैव दैट विल. ఓకే ఓకే డాక్, అయిపోయిందా పెట్రోల్? ఎంత టైం? బా చూద్దాం, నెఫ్రాలజీ ఖతం చేసిపోవాలి ఎట్లయినా, లేకుంటే వదలదు ఇది. ఆర్ యు హంగ్రీ? హౌ మెనీ హంగ్రీ? 1 2 అబ్బా, మీరు స్విగ్గీ ఆర్డర్ పెట్టి వాడు తెచ్చే లోపల చెప్పేద్దాం, నెఫ్రాలజీ పూర్తి చేద్దాం. సో what is this, doctor? This is the crescent. इसमें fibrin है, macrophages है, monocytes है, proliferating parietal epithelial cells भी हैं. This is another example of what? Crescent. Okay? Is another example. So now let us quickly talk about good posture. Good posture में anti-GBM antibodies are formed. GBM is there in pulmonary capillary endothelium, also in the kidney. इसलिए kidney से hematuria, lung से hemoptysis, both will be there. But here antigen is fixed on the tissue, a free floating antibody came and attacked it. Hence it is an example of type 2 hypersensitivity. How do you treat? Get rid of anti-GBM antibody by doing plasmapheresis. You take the plasma, send into machine, clean that, and then reinfuse, just like dialysis, but only plasma. And here, what is happening? IgA is coming and depositing along the GBM. Hence, it looks like a ribbon if you do immunofluorescence. Easy to remember. Then comes DPGN, diffuse proliferate. Diffuse means more than 50% affected. Commonly, diffuse proliferative glomerulonephritis is the hallmark of SLE. And what are these lesions of the SLE called as wire loop lesions? And how does DPGN? Only two conditions, DPGN, MPGN. Diffuse proliferative glomerulonephritis, membranoproliferative glomerulonephritis. Diffuse proliferative glomerulonephritis में only cells are proliferating, not GBM is thickened. MPGN में membrane is thickened, cellularity also is increased. And membranous glomerulopathy में only GBM thickened but cellularity is not increased. మూడు గుర్తుంటుందా? DPGN అంటే diffuse proliferative, no GBM thickening. MPGN అంటే membrane thickened and cells proliferated. Membranous nephropathy ante only membrane thickened but not cells proliferative. Simple. Nephrologists को उतना हुशार नहीं रहते. So there is a wire looping of capillaries. If you do immunofluorescence in DPGN, you get all granular appearance. And where are the deposits in this? Sub-endothelial. इसके पहले PSGN में sub-epithelial. So one sub-endothelial deposits, another will go and deposit underneath the epithelium. Another will deposit intramembranous, that is within the GBM. So మూడు రకాల డిపాజిట్లు అండి. ఏమిటి? Intramembranous, sub-epithelial, sub-endothelial. Where is endothelium? You have all capillaries, no, glomerular capillaries. उसका एंडोथेलियम रहते हैं ना, उसके नीचे हुआ तो सब एंडोथेलियल, जीबीएम के नीचे हुआ तो सब एपिथेलियल, और जीबीएम के अंदर हुआ तो इंट्रामेम्ब्रेनस. सिंपल, राइट? नाउ what do you see here? Extensive immune complex deposition with the thickened glomerular capillary loops, which is called wire loop appearance, seen in the case of the lupus nephritis in SLE. Now comes Alport syndrome. Alport syndrome may, what is the problem? Type 4 collagen. How many types of collagen you know? Many types are there. 1, 2, 3, 4. 4 is floored. So basement membrane is type 4. right? Then one is bone. So one is there in the bone. Anyway, when you come for entrance preparation, we will make you kadak karke bitayenge. Huh? So 4 is affected means who is affected? Basement membrane. So that is the reason there is a thinning and thickening of the basement membrane. And basement membrane becomes split. So splitting of the basement membrane with irregular thinning and thickening. And this kind of alternating thinning, thickening with the splitting will give what is called basket weave appearance of GBM. It is X-linked dominant condition because COL4A5 gene is affected. Call for collagen, 4 is for type 4. And what are the problems that you will have? Retinopathy, wherever GBM, basement membrane is there, all those tissues affected. Retinopathy, anterior lenticonus, that is subluxation of the lens anteriorly, glomerulonephritis, and sensory neural deafness. He can't see retinopathy and lenticonus. He can't pee because of the glomerulonephritis. He can't hear even a bee because of the sensory neural deafness, which is a high frequency hearing loss. Mala ENT lo different hearing losses, Urine's test, Weber's test, anta unnadi. The karma which we left there, no, will follow us and haunt us until entrance is over. So basket weave appearance. Fatafat dekhenge. Here you can see the glomerular basement membrane show irregular thickening and thinning and splitting along with accumulation of the neutral fats and mucopolysaccharides in the GBM in Alport. Finish. Then comes MPGN, membranoproliferative glomerulonephritis. That means membrane is affected. Also there is a cellular proliferation in MPGN. To add misery of our life, there are 2 types, MPGN type 1, MPGN type 2. इसमें 3 point, उसमें 3 point, बाद में love letter is ready, right? MPGN type 1. Type 1 is secondary to hepatitis B or C infection. Or it can be idiopathic. And all the immune complex deposits in type 1 are subendothelial with granular appearance of immune, just like DPGN. Type 2, it is associated with C3 nephritic factor. What is C3 nephritic factor? It is an antibody against the C3 convertase, but a special antibody. What is that? Antibodies destroy, but this antibody stabilizes. So IgG autoantibody that stabilizes the C3 convertase, which will continue to complement activation करते जाता हो, इसके वजह से इसमें hypocomplementemia रहेगा. Complement pathway winner है डॉक्टर गारू, alternate pathway, classical pathway, terminal complement components, which is anaphylatoxin, which is chemotoxin among the complements అదంతా వస్తుంటది. ఒక 10 పాయింట్లు ఉంటాయి, అన్ని నంబర్లే. ఇందులో 20 పాయింట్లు, ఇందులో 10 పాయింట్లు, ఇందులో 5 పాయింట్లు, ఇందులో 3 పాయింట్లు, అట్లా గుర్తుపెట్టుకుంటే చివరికి అవి తట్టడే 20,000 పాయింట్లు అవుతాయి. ఆ 20,000 ఇట్లా క్యారీ చేసి ఎంట్రన్స్లో పడేస్తే అయిపోతుంది, టాప్ ర్యాంక్ వస్తుంది. इसके लिए इंटेलिजेंस नहीं चाहिए. क्या चाहिए? फेविकॉल लगाओ, सीट पे बैठ जाओ, नहीं उठना और पढ़ते जाना. If bladder is full, put a Foley catheter, but don't get up. Right? Self intermittent catheterization is the secret of becoming a neat pitching. Tomorrow when you become neat pitching topic, YouTube में आता ना. What's the secret of, what is the shortcut to become a topper? Intermittent catheterization and sitting in Dr. Murli Bharadwaj's reading room. Okay, so tell me, doctor, what is type 2? C3 nephritic factor is an IgG antibody that stabilizes C3 convertase, which continuously convert the C3 and lead to low C3 levels. And in this deposits are intramembranous. Type 1 में subendothelial. मैं परसों पूछूंगा भूल जाते हैं आप. Which is associated with hepatitis B and C infection? Type 1. Right? And in both the types, mesangium will grow. Mesangio, membranoproliferative, in both the things, mesangium will grow. And that growing mesangium will go and split the GBM into, splits the glomerular basement membrane. Glomerular basement membrane को split करेगा. उसके वजह से it looks like a tram track. जैसे कोलकाता में रहता ना ट्रेन्स, tram track within the city. So tram track on H&E and PAS stains. PAS बोले तो क्या है बेटा? Periodic acid shift stain. HE बोले तो hematoxylin eosin stain. So what is this called? Increased glomerular cellularity with the proliferation of mesangial cells is what you need to remember. So let us look stepwise into the pathology. There is a subendothelial immune complex deposition. Immune complex underneath the endothelial cells will initiate the inflammation. That activates the mesangial cells. They detect the deposits which are subendothelial, and to clear them, they act like macrophages. एंडोथेलियम के नीचे डिपॉजिट आ गया बोल के वो जाके उसको कुछ करेक्शन करेंगे बोल के आगे बढ़ता. That will lead to mesangial cell infiltration into the basement membrane. So mesangium with a good intention want to clear those subendothelial deposits. In the process, what it will do? It will unzip the basement membrane and split it. That gives the tram track appearance, which is the hallmark of MPGN type 2, not type 1. So what are you seeing here, doctor? The split glomerular basement membrane, which gives the appearance like a Google view of the tram track. Splitting. This is another example how on the light microscopy, tram tracking, you can see the GBM is having a track-like appearance seen aerially. Then all the deposits are intramembranous, directly into the GBM. Intramembranous deposits are classical. And this is another example of type 2 में intramembranous deposits in case of type 2 MPGN. Khatam. Quickly, two more. Glomerulonephritis, we'll go for lunch. What is minimal change disease? Light microscopy में कुछ भी नहीं दिखता. Only electron microscopy में podocytes are attenuated. That is minimal change disease. Effacement of podocytes, food processes on electron microscopy is minimal change disease. First, you need to understand certain things. Actually, I must show this slide first. So this is the RBC, doctor. What is this? Podocyte, which is responsible for our negative charges and preventing the proteinuria. These are the mesangial cells, and this is the mesangial matrix. So you can see these podocytes are having what? Food processes. And this is what? Endothelium. This fenestrated capillary is there, no? This is the fenestrated capillary endothelium in kidney. Once more, how many types of capillaries, fenestrated capillaries, tight junctions, antunarikonta, physiology karma, which we left. Then behind that endothelium, what do you have? Basement membrane. Basement membrane. And what are these? Endothelial cells. తెలియాలి ఫండమెంటల్ స్ట్రక్చర్. ఆర్ వి క్లియర్? అప్పుడు ఇంట్రామెమరస్ అంటే ఏంటి, సబెపిథెలియల్ అంటే, సబెండోథెలియల్ అంటే ఏంటి, ఏది ఆడపోయి డిపాజిట్ అవుతుంది, మిసాంజియల్ ప్రొలిఫరేషన్ అంటే ఏంటి, మిసాంజియల్ సెల్స్ ఎక్కడున్నాయి, మిసాంజియల్ మ్యాట్రిక్స్ అంటే ఏంటి, समझ में आएगा. So it's a normal glomerulus. So light microscopy finding is what? Normal glomerulus. But if you look here, what are these podocytes? Normal capillary vein. Here it is completely balded. No podocytes. The podocytes seen here are not seen here. That is the hallmark of electron microscopy in. So normally here podocytes are expected to be prominent, but there is a complete balding. There is no podocyte. Is another example. Diffuse, you can see only the GBM. Where is the podocyte? Podocytes are all gone in case of nephrotic syndrome. Then oka rende unnai, FSGS and membranous nephropathy. Baad mein we'll rest to peace. Right? FSGS, focal segmental glomerulosclerosis. इसका स्टोरी क्या है? It can be idiopathic, like many nephrologists who are idiots. Then it can be secondary. ఈ లిస్ట్ సెకండరీ కాజెస్ ఆఫ్ FSGS అనేది నీట్ పీజీ ఎగ్జామినర్కి కొకైన్. యూ నీడ్ టు నో దిస్ లిస్ట్. సో HIV, sickle cell disease, heroin use, obesity, simple obesity. Mesomorphic Amjad Khan will have proteinuria with FSGS. Interferon treatment can cause FSGS, any congenital malformations also. Now, if it is a primary disease, idiopathic, all problems are with idiopathic conditions. It is inconsistent to steroid response. Steroid दिए तो उतना बात सुनेगा नहीं. And FSGS can proceed into chronic kidney disease, ultimately requiring dialysis. On light microscopy, what do you see? It is focal, less than 50% glomeruli. Segmental, what do you see? Sclerosis. Just before we have seen FSGS में that hyaline like sclerotic changes. Immunofluorescence is often negative. There are no immune deposits in this story. But there is an effacement of food processes, just like in minimal change disease, even in FSGS. That's the reason FSGS, membranous nephropathy, minimal change disease. 3 conditions to remember whenever patient has got a nephrotic syndrome. What are the 3 conditions, Bolo? Minimal change disease in children, most common. Membranous nephropathy in adults, most common. And what else? FSGS. Kani, if the proteinuria is 3 grams, 2 grams, it can be minimal change disease or membranous nephropathy. But if the proteinuria is massive, 7 grams, 8 grams lost, appudu renal biopsy chesi FSGS pattukovali. Massive proteinuria, not just nephrotic range proteinuria. Massive, 7, 8 grams lost drastically is FSGS. Another common practice principle. Membranous nephropathy hai to. Membranous nephropathy occurs in adults presenting with proteinuria. Whenever membranous nephropathy is there, commonly there is an internal lymphoreticular malignancy. లోపల లింఫోమా ఉంటే బయట membranous nephropathy బయటపడుతుంది. So what will you remember? Whenever elderly person with membranous nephropathy comes to you with proteinuria, nephrotic syndrome, just don't leave him. You need to evaluate for underlying lymphoreticular malignancy. Is a very important principle. Right? But common clinical practice lo challenges emuntayi? Nephrotic syndrome, nephrotic range proteinuria is there. So you are thinking, oh, is it minimal change disease or focal segmental glomerulosclerosis, or it is membranous nephropathy. None of them are the common causes in elderly person. What he will be having? Sugar. Diabetic nephropathy is the most common cause. Understand? Diabetic nephropathy is most common cause. You don't need to do renal biopsy if it is a simple diabetic nephropathy. But what is the very important principle? Between neuropathy, retinopathy and nephropathy, who will develop first? Retinopathy. A nephropathy without retinopathy cannot be diabetic nephropathy. Any nephropathy need to be called as diabetic nephropathy, need to undergo fundus examination. Only when retinopathy is there, then only that nephropathy is because of ఇది ఫండమెంటల్ ప్రిన్సిపల్. సో మీరు బుచ్చిరెడ్డి గారికి నెఫ్రాటిక్ రేంజ్ ప్రోటీన్యూరియా ఉంది, షుగర్ ఉంది కాబట్టి యూ కాన్ సింప్లీ జంప్ టు ఏ కంక్లూషన్ దట్ ఇట్ ఈస్ diabetic nephropathy. You have done fundus and no retinopathy. Then you need to do renal biopsy and see whether it is membranous nephropathy, and you will find Buchireddy garu is having lymphoma. Adi, that is whole nephrologist day is gone into. Patient number 1, let's do biopsy. Patient number 2, not required. Patient number 3, not required. Patient number 4, hey, he has got retinopathy. That's the reason he is a diabetic nephropathy patient only. So every day average nephrologist will do 4 to 5 सूदी लगाओ biopsy करो, सूदी लगाओ biopsy करो. So that is the reason when you become super specialist, 1 or 2 skills every day you will practice. ENT logo, tonsil आ गया तो हाँ नहीं. What did you say? Shimla. Okay, we are going to Shimla because I got 2 tonsils today. So it is a bread and butter, tonsillectomy. Caesarean hysterectomy is bread and butter of ASEAN. Charminar area में after 5 years देख लो. Uterus eradication program. पॉपुलर फॉर लैप्रोस्कोपी करके पीसेस मैश करके बाहर निकाल देगा को. नी रिप्लेसमेंट्स आर ऑल ऑर्थोपेडिशियन. अम्मा చేయించుకోమ్మా ప్లీజ్ అమ్మా చేయించుకో తల్లి, 1,00,000 రూపాయల్లో చేసి పెడతామ్మా, 50,000లో చేసి పెడతానమ్మా. హే ఆ డాక్టర్ గారు అయితే కనుక దసరా డిస్కౌంట్ 30,000కే చేస్తా అంటాడు. నీ రీప్లేస్మెంట్ నువ్వు కూడా ట్రై చేయరాదు. So ultimately practice is different from what you are now. All right, this is what doctor, you can see all that fibrosis in case of FSGS. This is another example. Where do you see the fibrosis? Here. So some scar will form. HIV patients may, infective endocarditis may, heroin drug abusers may, in all these people, that initiates a sclerosis, focal, glomerular, segmental sclerosis. Then comes membranous nephropathy quickly. So it can be primary. Where do you find primary? If there are antibodies to phospholipase A2, they can lead to membranous thickening and lead to primary membranous nephropathy. Membranous nephropathy can be secondary. Those who take NSAIDs, penicillamine, gold, HBV, HCV, syphilis, SLE, solid tumors. So SLE can cause diffuse proliferative glomerulonephritis. SLE can cause membranous glomerulonephritis. SLE can cause anything. Membranoproliferative also. Then in membranous nephropathy, just like minimal change disease, because there is a proteinuria, antithrombin 3 is lost and they have a prothrombotic tendency. Because of that prothrombotic tendency, they can develop a DVT, they can develop a renal vein thrombosis. When renal vein get thrombosed, vein, not artery, vein, renal vein thrombosed, that itself can present with nephrotic syndrome. So practice is थोड़ा subject है तो मजे में practice कर सकते, right? So if it is the primary disease, means antibodies to phospholipase A2 leading to membranous nephropathy, it has got a poor response to steroids. Always primary causes will have poor steroid responsiveness. Light microscopy mein what do you see? GBM thickening, diffuse capillary thickening, GBM thickening. And how will be the deposits in this case in membranous nephropathy? They will be subepithelial. Mala subepithelial ekkadunde? PSGN. PSGN lo subepithelial. Membranous lo subepithelial. MPGN type 1 lo subendothelial. MPGN type 2 lo intramembranous. Mari gade kada. Glomerular nephritis ante mazane ekkada depositlu unnayi ani cheppinode పాండిత్యం ఉన్నట్టు. Then it presents with nephrotic syndrome. So what are these, doctor? That the deposits of IgG and complement along the basement membrane in a diffuse granular pattern. What is this, doctor? These are the spikes of the basement membrane. Spikes of the basement membrane is what you are able to see. Then this is a membranous nephropathy where the capillary loops are thickened and they are very prominent. And what are these, doctor? These are once more spikes. Spikes seen in the matrix of basement membrane. That's all. Then comes amyloidosis. Amyloidosis ante em stain adi? Congo red, where you find pink hyaline deposits in amyloidosis. Amyloidosis may kidney involves, liver involves, lung involves, heart involves. Amyloid can involve anything. But kidney most commonly involved in systemic amyloidosis. So there's an AL amyloid, A amyloid, and any prolonged dialysis also causes beta-2 globulin to form amyloid protein that is called dialysis-associated amyloidosis. If you do Congo red stain, it will show apple green birefringence, and amyloidosis also presents with nephrotic syndrome. So what are these, doctor? Pink hyaline deposits seen caused by amyloid deposits. These are all pink amyloid deposits. And what are the conditions where there is a renal disease, chronic kidney disease, but kidney size is normal? Chronic kidney disease will cause a shrinkage of the kidney, but kidney size is normal. One is diabetic nephropathy when there is a CKD, kidney size doesn't shrink. Amyloidosis, in fact, kidney size increases. ADPKD, autosomal dominant polycystic kidney disease, when it leads to chronic kidney disease, size is increased. All other conditions leading to chronic kidney disease, size is decreased. Then comes diabetic glomerulopathy. Day in and day out affair. The most common cause of end-stage renal disease is diabetic glomerulopathy. Why? Diabetes may lot of sugar that will go and cause a non-enzymatic glycation of the tissue proteins. What are they called as? Amidory products, they are called as. They are AGEs, advanced glycosylated end products. Amidory proteins, they are called as. So they in turn will go and deposit everywhere they want. So they lead to GBM thickening that increases the permeability. Don't tell me, sir, GBM thin hai to permeability padega ya thick hai to padega. Medicine is subject like that. Thickening also lead to increased permeability. And there's a hyperfiltration. GFR initially will increase. Why? Because this GBM thickening this amidory products will damage the blood vessels. making them stiff. That will make afferent arteriolar pressure to increase, and that will squeeze the glomerular filtrate, increasing the GFR initially. That's called the phase of hyperfiltration. There is a glomerular hypertrophy, glomerular scarring, that progresses into nephropathy ultimately. అందుకే డయాబెటీస్ ఉన్న వాళ్ళందరికీ ఏం చేయాలి? 6 monthsకి ఒకసారి ప్రోటీన్ 1+ ఉందా, 2+ ఉందా, 3+ ఉందా చూసుకుంటూ ఉండాలి. సో if the proteinuria is worsening, that means their sugar control is bad. Okay? And you need to tell them your proteinuria is progressing, your hematology products are increasing, you are in a hyperfiltration stage. Time will come where you become, glomerular becomes sclerotic, you end in end-stage renal disease, you lead to dialysis, you will die in my hands. Don't tell like that. Nephrologists rob the hope of the patients very commonly. Right? You need to, best way to bring compliance for any patient and make him health conscious and to control his sugar is, take him and show another patient. ये बैठ गया patient. In your OP, another guy ready for dialysis is there. उनको बुलाओ, उनको बिठा के ఎన్ని రోజుల నుంచి ఉంది మీకు షుగరు? 10 ఏళ్ల నుంచి. మీ గ్లైకోసిలేటెడ్ హిమోగ్లోబిన్ ఎంత ఉండేది? 12, 13, డబుల్ డిజిట్, నథింగ్, నెవర్ లెస్ దెన్ దట్ డాక్టర్. ఇప్పుడు ఎందుకు వచ్చారు? సార్ నా క్రియాటినిన్ గాట్ ఇంక్రీజ్డ్ అండ్ కిడ్నీ డయాలసిస్ అవసరం అన్నారు సార్ అంటే, this guy will get understands the problem. That's called as physician's influence by coercion. Coercion means इसको डरा रहे आप एक तरफ से बताए तो, right? Then okay, you call that patient. నీకు HbA1c ఎంత ఉందయా? సార్ 9 ఉండే సార్ లాస్ట్ మంత్. ఇప్పుడు ఎంత ఉంది? లాస్ట్ 2 months బ్యాక్. ఇప్పుడు ఎంత ఉంది? 6.2 ఉంది సార్. గుడ్. Always keep one bad, one good patient ready with you. Every time a new patient comes, the best way to educate him is to show them by example. Okay? Anyway, when you join practice, I'll tell you how to be a good human and good physician. That's important in society. So, in diabetic glomerulopathy, mesangium expands, GBM thickens. There will be nodules formed, which are called Kimmelstein-Wilson's lesions. I'll show you. So, what do you see here, doctor? Nodules of pink hyaline material in the glomerular capillary. And the nodular glomerulosclerosis, Kimmelstein-Wilson's lesions are the hallmark of diabetic nephropathy. This is another example of nodular Kimmelstein-Wilson's lesions. And this is how it leads to diffuse proliferative glomerulopathy diabetes. That's all. ये చిన్న చిన్న cystitis, pyelonephritis లాంటి మీరు చదువుకోవచ్చు. There's no big deal. Okay, doctor. So, thank you very much for patient listening. What is the time? 2. So, మళ్ళీ మనం ఎప్పుడు మొదలు పెడతాము? నెక్స్ట్ ప్రసారం 2:45. Okay? So, did you like nephrology? The bad part of nephrology is over. Remaining is all good part. You don't need a teacher for that. Understand? Where the teacher is needed, I'll not leave you. Even if you don't want. And where you don't need teacher, even if you want, I won't teach. Because you need to be stimulated to read. What do you say, doctor? Are you information overloaded? No. Good. So, మధ్యాహ్నము కంటిన్యూ చేద్దాం అండ్ రేపటి నుంచి ఈవినింగ్ స్టార్ట్ చేద్దాం. క్రాష్ కోర్స్ ఎనాటమీతో మొదలు పెడదాం. 22,000 PYQs రివిజన్. సండే ఒక గ్రాండ్ టెస్ట్ అండ్ డిస్కషన్ చేద్దాం. full scale grant test paper and discussion. So next 16 weeks, Yatra Yogeshwara Krishno Tatra Pardho Dhanurdharaha Tatra Sri Vijayodbhutihi. Yatra Yogeshwara Krishno, where a yogi, a chariot called Krishna, and Tatra Pardho Dhanurdharaha, a warrior called Arjuna, go to the battle called Nitpiji, only winning and nothing less than winning. That should be the goal. Okay, doctor? So, some more students are coming down from tomorrow. So, we'll form a small group. Then revise. Rose ko 3 గంటల్లో we'll finish ఒక 500 PYQs. So, 20,000 PYQs అయిపోతాయి ఒక 16 weeks లో. And మీరు 30 mock test ప్రాక్టీస్ చేశారనుకోండి ఇంకెవ్వరు ఆపలేరు. Only we should plan to go to Chandigarh PGI or AIMS Delhi. Right? So that's the plan. Chalo, let's start. And Meeru, final year Balu, if you want surgery, let me know. Not 1 or 2, I cannot teach it. At least 10 students join in a good and surgery 2 दिन में खत्म करता हूँ, 3 दिन में. What the mother topic is 24, but the response should come from you. If you say, then I will. You are also entrance preparing, huh? Atlana, Namira. Good.
చాలా ఫోన్ అవుతుంది. బ్రౌన్ కలర్ సూట్ కేసు ఉంది కదా, దాంట్లో పైన పాకెట్లో చిన్న బ్లాక్ కలర్ పెడతారు చూడండి, అది పనిచేస్తుంది.